We will move on to the first section on acute meningitis and meningoencephalitis by Dr. Praveen Kumar. Sir, please.
Very good morning. So the topic given to me was acute meningoencephalitis in intensive care unit. I was happy because if it is a meningoencephalitis, you have to kind of include chronic meningoencephalitis, and I don't want to talk about cryptococcal meningitis with Arun Lok sir being there. So, so what we are going to do today is we are going to look into some of the practical aspects when you have a patient with altered sensorium and when you are suspecting meningoencephalitis. There are few things which you'll be always worried about, right? So these are the questions which we keep discussing, which we will kind of sort it out today. How much is the ceftriaxone resistance in the pneumococcus? Because pneumococcus is one of the most common cause of meningoencephalitis. And shall we give steroids or not? If we are going to give steroids, when should we give? We are not sure about the diagnosis of microbiological diagnosis of the etiology of meningoencephalitis at the admission. So it can be bacterial, it can be viral, it can be fungal. So are you going to give steroids or not? That's the dilemma which we have. And many of our patients will have hydrocephalus. Hydrocephalus is pretty common in tubercular meningitis, which again can land up in intensive care unit. Approximately 60 to 70% of the patients can have TB meningitis in some of the studies. So you always ask for a neurosurgeon to see the patient, and then you get something like let the patient deteriorate, then we'll put a EVD or VP shunt. That's when we are going to plan. Now the problem is there is no data to actually know when exactly to intervene. If you are going to put a EVD in all the patients, it will be too much. But if you are waiting for the patient to deteriorate, many of the times it won't be helpful. So the data in this area is very there is no data basically. So basically we are going to discuss a little bit of nuances. Probably we will try to come to a conclusion which may or may not be right. And many times once the patient gets admitted in ICU, you have done an LP, you have done an MRA. Findings in lumbar puncture, CSF is very non-specific, and you have seen an MRA not very conclusive. You are not able to see those tuberculomas to diagnose the patient as TB meningitis, and you have run a biofare that is also negative. Now you are having a case of meningoencephalitis with no diagnosis. Probably that is where you ask the ID to come and see, as if ID physicians are multiplex PCR. So they will also, obviously it's very difficult to know. Many of the meningitis go undiagnosed, and recent times we are using NGS, but that is also not helping much in the etiological diagnosis of meningoencephalitis when you are already using biofare. So when we are discussing all this, the patient is intubated and he develops a CRAB. So whole discussion on managing meningoencephalitis will directly shift to management of carbapenem resistant Acinetobacter baumannii, where you'll be using all the polymyxin and stuff. And patients sometimes they improve with tracheostomy and sometimes they deteriorate. Even though we keep citing that the mortality, for example, something like in herpes encephalitis is 30%, and we are assuming that 70% are surviving. But if you look into that 70%, 50% of the people will have very bad morbidity. They will be not functional to the baseline, and many of them will have delayed mortality after discharge from the intensive care unit to home. And the recovery of that patient, even with neurological deficits, really depends upon the nursing care and supportive care the family can provide at home. So if you add that 50 percentage, so 30 plus 35, so you're looking at something like 65 75%, 65 to 70% of the cases, in most of the case of meningoencephalitis, not doing well, not able to go back to the routine. Sometimes we don't even recognize that there are some subtle cognitive deficits which patients persist to have, which might affect the patient's long-term life quality of the life, which we think that the patient is tracheostomy, weaned off the ventilator, tracheostomy is removed, and patient is walking. We are happy about it. So all these issues are there. So when you give a consult to ID physician that the patient is not improving, shall we escalate antibiotics? So I'm going to come and tell you that see all the worsening in meningoencephalitis is not going to happen just because of the infection. So there are six important things. The mnemonic which made by my resident is he hits. So you can see that he is hitting someone. So he hits is hydrocephalus, edema, hemorrhage, ischemia, thrombosis, and seizures. So I'm not a great fan of mnemonics, but this is something which is very helpful. So every time your patient who is diagnosed with a meningoencephalitis in intensive care unit, you have to think about at least six of these things, right? In this, you might be seeing that what is difference between ischemia and thrombosis. Ischemia is vasospasm, which is a very important issue in patients with meningoencephalitis, for which your intensive care units are actually trained to look at the cranial Doppler and can diagnose the vasospasm bedside. So if you have time, you go to one of the paper from Germany where they have done a uh, great supportive care in pneumococcal meningoencephalitis, and their overall mortality is 15%, which is quite low. In that, they were doing twice daily cranial Doppler to see vasospasm, and they have intervened if there is any vasospasm. So this is a very important complications which we don't understand. So today we'll discuss about when to start antibiotics. This is the first question. When to start steroids, and are there any contraindications? And we will answer both these questions. And beyond antibiotics, we discuss about hydrocephalus, edema, hemorrhage, ischemia, thrombosis, and seizures, how to manage these complications. And after that, I will discuss some of the cases with classical radiological findings and diagnosis in these patients and how we have managed those cases. They are very straightforward, simple cases, but there is something for you in these cases to learn. So in emergency, once the patient comes with meningoencephalitis, so you want to start antibiotics, right? You want to start antibiotics as early as possible. And the first dose of steroid has to be given before giving antibiotics. So whatever the studies are there, the mortality benefit is there in only in the arm where the patients received first dose of steroids before receiving antibiotic. Because once you start antibiotics, there could be a bad inflammatory reaction. So the benefit of steroids after starting antibiotics may not be there. So you want to start antibiotic early. Before that, you want to give steroid. But before giving antibiotic, you want to have a culture, or probably you want to do an LP. And before doing LP, you want to rule out an obstructive hydrocephalus, for which you have to get a CT. Now this is the cycle where you are stuck. So you want to get a CT, you want to get an appointment, but that is getting late. Then you have to do an LP. Sometimes you might not get the CSF space properly. It might take time, because of which you are delaying antibiotics and steroids. So the answer is you have to start antibiotics within 2 hours, not more than that. So every hour after 2 hours is going to increase the mortality by approximately 10%. And if you go beyond 6 hours, the odds ratio of mortality is more than 8 times. So you do whatever way you want to do, whatever you prefer. You are very sure that it is not cannot be a obstructive hydrocephalus. You want to go ahead with an LP upfront. You can do that. There are studies to support that also scientifically. Whatever you do, the idea is your first dose of antibiotic should go not more than 2 hours. So in between these 2 hours, you sort out everything. It really depends upon the place to place how you can do that, but you have to streamline it somehow and give the first dose of antibiotic within 2 hours and first dose of steroid before the first dose of antibiotic. So another question is whether we should be empirically adding vancomycin or not. Yesterday we have discussed that in India, pneumococcal meningitis strains are resistant to penicillins very commonly. So we have to add vancomycin upfront. Why people keep asking about vancomycin is because most of the times when you have a case of meningoencephalitis, you also want to keep the patient on acyclovir. So basically, you are kind of giving ceftriaxone with vancomycin and acyclovir and steroids. So acyclovir, vancomycin both can be nephrotoxic, and you have to be a little bit careful because acyclovir is excreted renally. So if you have a renal injury and if you are not dose modifying acyclovir itself is neurotoxic and can lead to a non-convulsive like status epilepticus, which is difficult to manage. Let us move to steroids. So basically, you have bacterial, tubercular, viral, fungal etiologies, and sometimes in refractory status epilepticus as an immunomodulator, we use steroids. So what about bacterial evidence from the bacterial meningitis? So basically, we have this trial which was done in 2002 by Van de Beek. This is the most important trial where the practice of giving steroids has changed. So in this particular study, which is done in high income countries, there is a mortality benefit, especially in a streptococcal pneumonia subgroup. And that was followed by a few more studies in lower income countries where they were not able to show any benefit, but there was no harm whatsoever. So basically, steroids is the standard of care from there. The typical dose is 40 mg daily for 4 days. That's what we use for pneumococcal meningitis. You can adjust it to body weight also, but this is the dose they have used. So since then we are using steroids. So now what comes is, what if it doesn't turn out to be pneumococcus? If it is some other bacteria, at least in these studies we know that there is no harm with even with other bacterial infections. Probably there is some benefit in the form of decreased hearing loss in H influenza patients, but other bacteria which are otherwise little rare to cause meningoencephalitis. But there is another concern with listeria. Listeria is an intracellular bug, and it is commonly seen in immunocompromised host extremes of the age and pregnancy. So there was study from the French cohort in 2017, which we call it as Mona Lisa study, where use of steroid was significantly associated with higher mortality. So from 2017 to probably 2022, whenever you go to some conference in ID, if you are discussing about meningoencephalitis, this study is cited. It has a lot of limitations. It's a retrospective study. There is an indication bias for these patients, and only 13% of the patients are actually received steroids. So obviously, the sicker patient might have received steroids. That could have driven the mortality. After that, in 2023, that is a Dutch cohort from Amsterdam. They have published another study, which is a prospectively done study. In this particular study, they were able to show actually steroids are associated with mortality benefit even in Listeria meningitis. So this confusion of Listeria meningitis contraindication of steroids is sorted out right now. What about viral encephalitis? So, what about HSV encephalitis? So, HSV or any other viral encephalitis. So, if you give steroids, are you going to do more harm than benefit? So, there is a study to address. This is a big study, DexNCath study. Big study in the sense the N is 94 because it is very difficult to recruit the patients with viral meningoencephalitis. And in this study, there was no benefit of steroids. But however, you have to understand that there is no harm of steroids also. It is very important to understand even in viral encephalitis, there is no harm. In fact, in a subset of patients where you are able to treat the patient very early before significant neuronal, there is signal towards mortality benefit in these patients. So even in herpes encephalitis, you are worried about herpes encephalitis. That should not make you not give steroids in these patients, because in emergency it is very difficult to know what it is exactly. What about tuberculosis? Tuberculosis, we give steroids for long time. The initial landmark study by Thwaites and the group in 2004 has shown significant mortality benefit in non-HIV patients with TB meningitis. In HIV patients, there was no signal, and there is a recent ACT HIV trial where in HIV patients, again, steroids are not associated with mortality benefit, but you have to understand that there is no harm as well. So, whatever is the etiology, if you are giving steroids, there is no harm till now. But what about cryptococcal meningitis? So, this is very interesting because cryptococcal meningitis usually happens in a deeply immunocompromised patients. I thought I skipped this slide. So in deeply immunocompromised patients, so there was a study called CryptoDex where they have used steroids just like TB meningitis to treat cryptococcal meningitis. There was no benefit. In fact, there is a trend towards harm, and there are increased side effects in these patients. But then you have to understand that the doses of steroids are quite high, given for 6 weeks. So if you are giving 6 weeks of steroids in the treatment of cryptococcal meningitis where you are not starting ART, there is a trend towards harm. So if you start steroids in emergency or ICU, after 2 days you get to know that it is cryptococcal meningitis, and if you stop steroids, that is not going to cause harm. So you should not be worried about the take-home messages. You should not be worried about starting steroids in a patient with meningitis before first dose of antibiotic. What about refractory status? Yesterday we have discussed some of the cases with super refractory status epilepticus where you are not able to control the seizures for more than 24 hours. This is where again the immunomodulation comes in. All the literature is again from the case series, case reports, but many of these patients you can actually give pulse dose of steroids and probably add a second immunosuppression. The way is to immunomodulate so that you can bring down the seizures in these patients who are super refractory status epilepticus. So you can use steroids there as well. Let us move to the complications of meningoencephalitis. Now, this is very important in the context of tuberculosis. So, hydrocephalus is one of the most important complications. Now, in TB meningitis, when you see, you always tend to compartmentalize the complications into hydrocephalus, basal meningeal enhancement, and thrombosis. But the reality is, all the three are interconnected. So, once you have hydrocephalus, there is a raised ICP. Raised ICP will cause decreased blood flow in the vessels, and if there is a sluggishness of blood flow in the vessels, it will get thrombosed. Once you have ischemia and thrombosis, there will be some inflammation. And in the periventricular area, if you have ischemia, the CSF absorption will be problematic. That will worsen the hydrocephalus. So basically, this is a vicious loop. Most of the studies where we are using steroids or we are trying to use aspirin, they tend to kind of neglect the other aspects. So if you look at the TB meningitis trials, which are broadly negative most of the time, you will not find how they have managed the case hydrocephalus. You will see 60% of the patients in the both arms will have hydrocephalus, but you cannot see how they have managed when they intervene. These things becomes very important because if you are trying to see the benefit of a new drug, if your standard of care is not uniform, so whatever benefit with the drug can be nullified. So the trial will go towards a non-inferiority. So that is one of the biggest problem in TB meningitis trials which are existing now. So what I'm trying to say is, you have a patient with a GCS of less than 10 who got intubated and hydrocephalus. Most of the times we will intervene. And you have a patient who is meningoencephalitis but talking to you. Even there is a hydrocephalus, you want to wait. The gray area is in between. If the patient's GCS is something less than 15, between 10, when you call a neurosurgeon, most of the times they will say that we will wait for 24 to 48 hours and reassess, then we will decide whether to put a EVD in this patient or not. Now, this is problem because in next 24 hours he gets a stroke. It can be a irreversible neurological damage. So we should be a little bit careful denying. And all this data neurosurgeons say that is from the trauma, neurotrauma, where the hydrocephalus is because of the clots, blood clots, which we are expecting to dissolve. But whereas in cases like TB meningitis, in fact, you are expecting it to worsen in next 48 hours, especially with the patients with the dense basal exudates. You give ATT, the inflammation is going to worsen. So you're not expecting it to improve suddenly. So some of the radiological features which I feel should be, you should be very careful. If there is a significant, if there is an obstructive hydrocephalus, anyway you have to intervene. That is easy. So basically, you have to see for the flow void on in aqueduct of sylvius. If it is not visible, then the CSF is not flowing. So you have to definitely intervene. If you are seeing a lot of periventricular ooze, that means the pressure is already very high and the CSF is getting pushed out into the white matter tracts. That is where you have to intervene. And in that periventricular ooze, if you're seeing diffusion restriction, that means the neuronal cells already started dying. So these radiological features, if you see, and the patient is, you are really a little bit confused about whether to intervene or not, it should be intervened. There is one way of looking into it. So people say that you put an EVD, and if the patient improves, that indicates the deterioration is because of hydrocephalus, and if the patient doesn't improve, probably hydrocephalus is not contributing. I think it's a little bit of simplistic view because, as we said, this hydrocephalus is a complex thing because one thing will lead to each other thing. So if you have multifactorial issues, you have to address all of them. Doesn't mean that you will not address hydrocephalus. What about pneumococcal meningitis? You all must be having this experience of treating pneumococcal meningitis. You put the patient on ceftriaxone and steroids. Some of the patients, by the time they come to emergency, you'll see that patient is already having some form of stroke. So if you do a MRI, you will see that there is areas of diffusion restriction and there is some ischemic stroke there. This is because pneumococcus has a very specific enzyme called neuraminidase, which breaks the sialic acids on the surface of the cells, especially endothelial cells. Now, sialic acid is something which will differentiate between own and something which is not own for the immunity. So the immunity will go and attack the endothelial cells. So pneumococcal disease is an endotheliopathy. You can see that even in pneumococcal pneumonia, you will always see some amount of thrombotic microangiopathy in pneumococcal, very bad pneumococcal disease, which we call it as pneumococcal HUS. So this is very common. There is one study comparing the incidence of stroke in meningococcus and pneumococcus, and you can see there is a stark difference. In meningococcal meningitis, the strokes are like 9%. In pneumococcal, it is like 36%. So definitely pneumococcus is something which is different. And once you start the patient on steroids, patient is improving, then you can again see that in the next 1 week, patient can suddenly deteriorate again once you have stopped steroids. So this is called delayed pneumococcal vasculopathy, very common. People used to believe that you are giving steroids, you are dampening the inflammation, and the moment for our dosing is 40 mg for 4 days, right? So fifth day onwards, you take off the steroids. When the steroids effects go, there will be a rebound inflammation, and there could be a delayed pneumococcal vasculopathy. This was the theory, but patients who are not receiving steroids also can develop delayed pneumococcal vasculopathy. So delayed pneumococcal vasculopathy is an issue, and it is most likely happening not only because of the thrombotic potential of the pneumococcus, but also because of the vasospasm. Now, this is the most important thing because you can actually intervene with this vasospasm. So, in the German cohort I was talking about, they have done twice daily transcranial Doppler, and if there is a vasospasm, they intervene by giving milrinone. Milrinone is it will decrease the vasospasm, and they had a very good outcomes in the patient. It's a single arm study, there are no comparative arm, but it's an interesting thing to actually assess. So pneumococcal vasculopathy is definitely an issue. We really don't know whether we should not be stopping the steroid suddenly. Shall we just taper it down rather than stopping on 4 days so that the rebound inflammation will not be there? What is the data with milrinone? There are only few case reports here and there where people have used milrinone for pneumococcal associated significant vasospasm, right? What about enterovirus? You with the use of biofare, we are going to see more and more of enteroviral infections, very common in children, which will present with hand, foot, mouth disease and meningoencephalitis. But at the same time, adult population who are on monoclonal antibodies like rituximab or daratumumab, which will decrease the immunoglobulins. So for enteroviruses, immunoglobulins are very important. Neutralizing antibodies are very important. So if you don't have neutralizing antibodies, the risk of enteroviral infection is increased. One of the most important aspect of enteroviral encephalitis, it is affects the brain stem, causes a sympathetic crisis. So patient will have hypertension, significant vasoconstriction because of the brainstem induced sympathetic crisis, brainstem injury induced sympathetic crisis, land up in neurogenic pulmonary edema, which obviously we can diagnose always as a hospital acquired infection and then start on polymyxin, right? So this pulmonary edema and tissue damage will cause cytokine surge, which will go back to the brain, which will affect the brainstem again, and this cycle will go on. So enteroviral encephalitis, it is very difficult. Patient will actually go into shock, and this loop will keeps going on. So you have to break this. And one of the interesting thing is in vitro there was a study where when people have given adrenaline to enterovirus, the viral proliferation has increased. So somehow probably this sympathetic surge is also increasing the proliferation of enterovirus. So in this particular entity, there is a very interesting trial done long back. It's an observation study first, pre and post study. So they started using milrinone. So milrinone is an inodilator. Sometimes it can drop BP, but if there is a BP is dropping, you can always use vasopressin rather than using adrenaline to hold the BP. So in this pre and post study, they have shown that milrinone is associated with significant decrease in mortality. The sample size is small, but again, you cannot expect a big sample size for enteroviral encephalitis. Is it the only evidence? They have followed it up with a RCT of approximately 40 patients, and there was a very clear signal of mortality benefit, and the mortality benefit, the effect estimate is quite huge. From then, actually in Taiwan, it became a routine to use milrinone in any children with brainstem encephalitis. So this is an important lesson which we are learning. So some of us are really interested in managing probably rabies, and whoever have managed rabies, you always listen to them then say we were able to manage rabies for 30 days, but then the patient landed up in autonomic storm and we were not able to manage it. Probably milrinone is the answer for that. So I will give a small break here. If there are any questions, 1 or 2 minutes, I can quickly take them. Then we will discuss some cases. No questions, sir? Yeah. You can give OD dose, sir, actually. Not required. This is somehow we are doing it. I don't know. Probably people are not comfortable giving 40 mg. 40 mg is like methylprednisolone 250 mg push. So it doesn't lead to a spike of sugars. Also, the half life is long. Biological half life is longer. So when we are discussing about dexamethasone, if you stop dexamethasone also, the immunosuppressive effect will continue for 3-4 more days. So usually it doesn't require the tapering which we do. And as you said, we can just give 40 mg once daily rather than dividing it into 10 mg 4 times.
Second thing is regarding the steroids and TB meningitis. So I know that steroids can increase the mortality because of an increase in Kaposi sarcoma when I use it for TB pericarditis.
Yeah.
So can I say that steroids can still harm these patients in HIV? It is anyway not going to help them. So can I extrapolate that data saying that it can cause a harm?
So the trial is negative. But if you ask any ID physician or whoever managing TB meningitis, everyone will be using steroids. There are a lot of limitations of how we do trials. Kaposi sarcoma as such is very rare thing to worry about, especially in India. So that should not be worry. The worry will be probably secondary infections, especially when the hospital environment is not good. We always keep thinking about something like Caritas Hospital, which is very clean. But you can see TB meningitis being managed in wards, and you can grossly see the fungus sitting there. I am not talking about fungus. There are cases where patients are on steroids for TB meningitis and they develop aspergillus, very bad aspergillus, and then die. This especially happens with the doses of steroids. The trials have used uh, zero point 0.4 mg per kg for 1 week, then 0.3, 0.2, zero point 0.1. But when you see most of the patients who are being TB meningitis, you can see patient will be continued on zero point 0.4 for 4 weeks. So people somehow don't come down on steroids. And you can sometimes actually see that when you are decreasing down on steroids, patient can transiently worsen also. So people are having that fear. So the doses of steroids where in India people are receiving are quite higher than what is studied in the trial in the first place. So I think that is something to take care of. Kaposi sarcoma should not be a worry in India because it's very rare in India as such.
But again, if it does not help, should I give it?
So it does not help is
In
the question.
In HIV positive, yeah.
It does not help is the point of debate right now. There is one trial which is negative, but there are limitations of how the trial is done. And then we are discussing a lot about phenotyping in tuberculosis, not just LTA4 polymorphisms which keep discussing. But I think the TB meningitis has to be seen in a very different way. Actually, we are working in this area. I cannot be surely telling you something, but probably in near future we'll come up with something how to phenotype tuberculosis rather than what we are doing right now.
So we talked about enterococcus.
Enteroviral, sir. Yeah.
Enterovirus, sorry. The vast majority of them are very mild, and
Yes,
in fact, if you get that report, you can be you can rest assured that nothing much will happen.
Yes, sir.
So, what percentage of enterovirus goes bad?
Sir, like I haven't seen many intraviral encephalitis first of all. Second thing is, as you said, this is not a problem in most of the times. These people are self-limiting aseptic meningitis like presentation. That's why the sample sizes were also very low. But it sometimes happens in outbreaks, and especially in immunocompromised patients, especially those on monoclonal antibodies like rituximab. Enterovirus is known to cause a fulminant disease and also can cause a very prolonged, like a chronic meningoencephalitis like picture also, where we commonly use IVIG. But if the patient lands up in this autonomic storm, so this study also the recruited they stage the enteroviral encephalitis into stage 1, 2, 3A, 3B, and 3A is where they started seeing autonomic dysfunction. So stage 1, 2 they won't give millinone for this patient. Only for the very sicker patients who are landing up in ICU, probably they have to use millinone. But I think it also gives us very important information about how we are managing autonomic storm in other viral encephalitis. For example, Nipah. So if do they land up in this autonomic dysfunction, sir? Brainstem. So probably that is the area where we can extrapolate the data from there to manage these patients, especially when we are having difficulty. So, sir.
First, you need to look into the epidemiology.
What
Sir.
is the percentage of which infection is common?
Yes.
Then only you start thinking in this way your algorithm for management.
Yes, sir.
So I think that is most important.
Yeah.
Yes, they like suppose if you thinking of the crypto is very rare in case of non-HIV group, and in this situation, only thing you start about when you are doing LP can easily do this aspect. So I'm saying you the epidemiology of that area and the viral factors is having got lot things with seasonal situation. So all these factors need to be taken into account while managing this.
Yes, sir. Absolutely right. So these cases, this whatever we have discussed is the areas which we usually don't think about a lot. That's the reason why I kept it. I will be discussing some of the cases which are common cases day in and day out we will be seeing with some challenges in that. So I will move forward with my cases now. So this is the favorite of anyone coming from Manipal, worker who is working in Areca nut, had a KFD first phase, then improved, and they come to your hospital with cerebellar symptoms, KFD second phase. What was happening is when we are doing MRI of these patients, every time the MRI is like normal, with a gross clinical symptom suggestive of cerebellitis. So we thought, why not go for a functional scan? And you can see that the cerebellum is lit up in the brain PET CT. This is just for your interest, just a starter. This is the second most important interesting disease you see in Manipal. What you can see here, what you can see there where the arrow is there is a tunnel sign. So melioidosis is very interesting because it's the bacteria which does not lead to a lot of neutrophilic infiltration. That's why whenever you see melioidosis, In liver, you will see small abscesses coalescing together. Neurological melioidosis is very interesting because it has a transaxonal transport. So many times patients with lung infection into the mediastinum through the vagus nerve, it can reach the brainstem. Sinusitis through the trigeminal nerve endings, it can reach the brainstem. So it can have a retrograde neuronal transport. This happens especially in immunocompetent hosts. So usually when we talk about melioidosis, we talk about diabetic patients, but neuromyelioid, which is very aggressive, is actually something which is happening in immunocompetent. So young adults exposed to myelioid, the retrograde entry of the virus, brainstem encephalitis and death. Very difficult to diagnose because CSF will be usually negative. The radiological features are very important to identify these patients. And this is a classical tunnel sign. It is there in the splenium. I wanted to name it as boomerang abscess because it's looking like a boomerang. But this is important, right? So we have our group, Dr. Nitin Gupta, and we have done some of the studies. We have actually proposed this mechanism of transaxonal transport long back. Uh, Before that, there was an animal study which they have definitely proven. After that, there was a real world experience from CMC Vellore where there was an outbreak after dental surgeries where people have brainstem encephalitis with melioidosis. So this definitely proves that the myelioid has definitely has transaxonal transport, but it can also go retrograde from the cranial nerve ending into the brainstem, and it can also hematogenously seed into the gray matter white matter junction. And from there, it can trickle down through the white matter tract. So this tunnel sign is very important to identify because your treatment is going to change. And neuromyelioidosis may not be an immunocompromised host, which we expect. It can happen in it can happen in immunocompetent host. That is the important thing to learn. What about this, which we call it as, this is something which we call it as double donut sign. This is a spectrum of expanded dengue syndrome. Patient will come with dengue, may or may not have a classical signs of dengue sometimes. In expanded dengue syndrome, you will actually, expanded dengue syndrome is nothing but you should not be able to explain the end organ damage because of the capillary leak or shock. So if you are seeing a patient with dengue and you are not able to explain the symptoms because of shock or capillary leak, then it is expanded dengue. Can happen in the brain. So this we call as double donut, and everyone will take picture. Eventually, patient dies. So if you look into the pediatric literature again, it is very interesting that they have more clarity on what it is. They call it as acute necrotizing encephalopathy. Can happen with many viruses. It is not because of the virus. It is because of the inflammatory response which will affect the bilateral thalamus. That's the reason why it is always symmetrical with some necrosis and hemorrhage. With dengue, we can call it as DANE. There is a good paper on dengue associated necrotizing encephalopathy. Logically, it makes a lot of sense to block the cytokines in this patient, but not much data is there. Only case reports are there, right? This is again, you can see that there is amoeba with acanthopodia. This is the first case we have diagnosed in our center with granulomatous amoebic encephalitis. And we have given a cocktail of antibiotics and patient developed C. difficile, very bad C. difficile. After that, we kind of held our nerves and we started giving something called Mars regimen. We call it as Mars because miltefosine, albendazole, rifampicin, and Septron, let's go trimoxol. You can use your own regimen. After that, we have managed 5 or 6 cases, and we have been successful. But probably the way amoeba behaves, what actually it is, and what we learned all the time, probably it is little different. So, again, amoebic encephalitis. People ask me what are the features where we have to send amoebic PCR or look for a wet mount. I guess it is very difficult clinically, radiologically. The classical history you will not get, and many of the patients now are coming with very atypical manifestations. Recently, there is a paper by Dr. Arvind and group where they have shown that even long track signs are there in patients with amoebic meningoencephalitis. So at this point of time, I think it should be routine. If you are sending a biofire for enterovirus, which is kind of rare, you should also be sending amoebic PCR for all the patients and do a wet mount examination, which is not very costly. So when we are reading through amoeba, few of our residents are actually getting confused between what is primary amoebic encephalitis, what is granulomatous amoebic encephalitis, and our residents are smart people. So we are like, there is something wrong with this terminology. You cannot call primary because there is no secondary amoebic encephalitis. Are you trying to say that entamoeba is going into the brain? So the and granulomatous amoebic encephalitis, so-called granulomatous amoebic encephalitis, will have less than 30% of the patients had granulomas. So these are like misnomers which we are using for decades. So we were really irritated with this. So rather than calling it as primary and granulomatous, why don't we call it as flagellated and non-flagellated? Because flagellated Naegleria behaves very differently. Non-flagellated like Balamutia and amoeba behaves very differently. So we kind of published it in Lancet Microbe. We think that people will start calling it as flagellated and non-flagellated, but still now we use the same terminology which we use. This is a routine common encephalitis which we see in the ICU. It is herpes encephalitis, right? You can see bilateral insular cortex is involved, and you can see there is a anterior cingulate gyrus is also involved in this patient. Very classical picture of herpes encephalitis. We all know that herpes encephalitis has to be treated with its own, probably a only viral encephalitis we can, where we are very sure that antivirals will work, but you want to start antivirals as soon as possible, which you cannot do because the patient will be coming in the later part of the day. So for an undergraduate, if you ask what is there in herpes encephalitis, you have to give acyclovir 10 mg per kg 3 times a day, but it really gets complicated when the patient lands up in ICU. So in patients with herpes encephalitis, they will try to die at any cost. You have to kind of prevent that death. So the areas which we are seeing, which we are calling as insular cortex, if someone scolds me, I feel bad, and the feeling of bad is from insular cortex. I mean, it is connected to all the emotional centers and sympathetic and parasympathetic system. Right side is connected with sympathetic, left side with parasympathetic. So if you have a more of right sided involvement, patient is going to have tachyarrhythmias. This we know in stroke patients. Insular stroke, right side, they are associated with VTs, PSVTs, whereas left side patient will end up in bradyarrhythmias. Herpes encephalitis will have a asymmetrical involvement. Just imagine this firing sometime, and you have a patient who is fluctuating between high BP, low BP, high BP, and tachycardia, bradycardia. Now, it is not that simple also again. Once the patient is on ventilator and once he started breathing fast, what he will do is he will wash out all the CO2. And in meningoencephalitis, you want to have a strict control over CO2 being an intensivist. So you want to keep it between what, 35 to 45. And when the patient is breathing very fast, he can wash out the CO2 to 20, and suddenly there is a cerebral vasospasm. Now the resident comes to the rounds and he checks the pupil. We ask the resident to do a good clinical examination, and pupils are dilated. So resident is convinced that now there nothing we can do. He wants to present it in the round. When the consultant comes and checks the pupils are normal. This is because of the autonomic dysfunction that is associated with herpes encephalitis. It causes bad SADH. And if you, many of my colleagues, they'll be like, I don't want to manage sodium, potassium. This is what we usually do. But in herpes encephalitis, if you don't want to manage sodium, you're not managing herpes encephalitis, because if you have hyponatremia, there will be worsening cerebral edema. So all these things will make sure, like, patient will try to die, and you have to kind of prevent this death. And I feel that the neurological outcome, 50% of the patients who are not having good neurological outcome, we can prevent that by looking into these issues. This is the area, again, insular cortex is the area which is very rapidly firing. It is connected to the frontal, parietal, occipital lobes, and it is very seizure prone. So once you have seizures in this area, patient can have status epilepticus. Many times these patients require muscle relaxants also, because there is a lot of atomic fluctuation. So once the patient you have put the patient on muscle relaxation, patient is not going to convulse. So non-convulsive status epilepticus is something which you are worried about. The problem is, in such situations, ideally you should have a 24-hour EEG monitoring so that you can actually adjust the treatment. Unfortunately, most of our ICUs do not have 24-hour EEG monitoring. So once the patient has status, when to come down on antiepileptics, when you're decreasing infusion, you want to get an EEG again just to see whether the seizures have gone down or not. So this becomes very, very complicated. So we had one patient who had a super refractory status epilepticus. We have loaded her with a the huge doses of levera. In status epilepticus, you don't give 1 gram of levera. The data is with 3 or 4 grams, 50 mg per kg. Many times I ask my resident, how much you give? Sir, ideally it should be given 3 grams, but we give 1 gram. So why do you give 1 gram? You have to supposed to give it 3 grams, right? So good doses of levera, propofol, midas infusion. And if your seizures are going for longer time, the GABA activity will come down and NMDA will kick in. So you want to add ketamine as soon as possible. So we have done everything. Then we wanted to do immunomodulation. So we gave a pulse of methylprednisolone for 3 days. No response actually. Despite of all these things, patient is continued to have seizures. The moment in between there are periods of seizure free period, but we are not able to kind of really have a control. Then we switch to something called keto diet. Now there is some data with the keto diet in intensive care unit. If you have a super refractory seizures, you can actually induce ketosis, which will decrease the seizure threshold. Now induction of ketosis in ICU, this is the first time we were doing. So my residents are so good that you give this idea, shall we do keto diet? They'll be ready with a chart, a diet chart, how to do keto diet. So so it is very difficult to induce ketosis. That is what we learned. So you are planning a diet 4:1 ratios of lipid and carbs, and then someone comes give a DNS infusion that day because patient is NPO, planned for an MRA or something. The ketosis is very difficult to attain. These patient seizures have actually settled, but we were not able to actually induce ketosis. So we are monitoring the urine ketones daily. We are not able to induce ketosis. Despite of the fever, patient seizures settled. She went home with a lot of morbidity and she expired after 3-4 months. So that is more important. The delayed mortality is something which we tend to forget. Now, this is another case who was referred from UAE to second opinion and almost became the line of management is becoming palliative because already a month, more than a month, in fact, when by the time she came. And they had an extensive evaluation, including biofires, NGS, and all the PCRs, and whatnot, amoebic PCR. So we wanted to see amoeba. Everything is done. Everything is negative. We are thinking in the lines of, is it a primary sinus vasculitis because patient had some strokes. So we have to understand that there are only few etiologies which will have meningitis with stroke like presentation. If you exclude everything, you call it as primary sinus vasculitis. Besides that, TB, pneumococcus, and varicella zoster and amoebic encephalitis. So the problem with VZV is when we are labeling something as VZV vasculopathy, you are not expecting the virus in the CSF. So virus PCR will be always negative. What you have to do is a VZV index. So especially in meningoencephalitis with stroke, if you are not getting anything, you have to be really thinking about VZV. So you do a VZV in the CSF, IgG, and VZV in the blood IgG, and then you have to adjust for CSF penetration. That you can do by doing CSF IgG and serum IgG, or you can also do by CSF albumin by serum albumin. So this patient we have done that, and VZV index was quite high in this patient. So it is about 9. So she was diagnosed as VZV vasculopathy. And patients with VZV vasculopathy, once you start acyclovir, you'll see the drastic response in these patients. The patient who was almost even M1 not responding, almost became palliative, started communicating with the relative. So at the time of discharge, she was not mobilized yet, but she was communicating and the family was very happy. So this is something which we should know about, especially when we are dealing with negative CSF negative meningitis. What about this? This is the RVD case. You can see that there is an eccentric rings, and we call it as very classical of toxoplasmosis. So if you see an RVD patient and you see this radiology, the diagnosis is kind of confirmed, and it affects the basal ganglia and thalamus areas. So quite easy, right? So these patients, when you start them on cotrimoxazole, they respond very quickly. You do a MRI after 2 weeks, there will be significant improvement. In fact, the clinical improvement will come in 4 or 5 days. So most of these patients will do very well, and we are very sure about what we are dealing with. So this patient again got admitted, last case, got admitted, and we are treating it as toxoplasma. We done a repeat MRI after a week. You can see there is a very significant improvement. So it fits into toxoplasma, CNS toxoplasmosis. The problem is he was not improving. Initially, it was labeled as probably patient was having alcohol, patient is having alcohol withdrawal. So he is having intermittent episodes of tachypnea, just like an autonomic dysfunction. We looked for seizures. There were no seizures. EEG was not showing any seizures. So these episodes, the respiratory rate goes high, and there will be, if your respiratory rate very increased, your expiratory time will come down. So you can actually see autopep, and then patient is having autopep. So all these episodes were diagnosed as bronchospasm once, seizure some other time, got a Levera shot, sometimes got sedated. So this delayed his extubation, eventually leading to tracheostomy. Even after tracheostomy, we are not able to take him out of ventilator. And when we took out of ventilator, when we are managing, again these episodes keep happening. In between he is normal, but there is a sudden episode where patient breathes very fastly. There will be high spiking fever, diagnosed as sepsis many times. Antibiotics were changed, and at that time there you can see dystonia, where you can actually think it could be a seizure. So we are kind of frustrated, and when you are very angry, you get new thoughts. So that time we diagnose him as paroxysmal sympathetic hyperactivity. This can happen, especially lesions in diencephalon. Toxoplasmosis, it affects the thalamus, so it can happen. And these are the episodes where the pupil is dilated. There you can see the dystonia, and patient is having tachycardia, a lot of secretions, right? So this is paroxysmal sympathetic hyperactivity, and these are all the differentials we dealt with when we are managing this patient. And And there is a criteria, diagnostic criteria, of obviously after excluding everything else. And this patient is the probable PSH, and you manage PSH based on the episode. So you give some baseline drugs to prevent these episodes, and during episodes you have a way of managing. So eventually, these patients, once patient develop paroxysmal sympathetic hyperactivity, it takes a very long for them to recover. So he had a very long stay. Eventually, these episodes were controlled, and he was sent home. However, after a few days, he had a tracheoesophageal fistula. So he started vomiting from the tracheostomy tube, and that is the time where we could not do much. So he expired eventually. So thank you very much. If there are any questions, I will take that.
Thank you, sir, for your wonderful presentation. Next, let me invite Dr. Parshit for a session on antibiotic associated diarrhea and C. diff infection.
Good morning, everyone. I'm going to be talking about C. diff and how do you diagnose it in our settings. What can we do in our settings for the management? So let us. Oh, sorry. Let us look at the pathophysiology of C. diff. There are studies which show that up to 10 to 15% of the people, not just patients, of people are colonized with C. diff, and this incidence can be higher in residents who are in long-term facilities. Healthcare workers, especially, can be colonized. In this room, maybe 15% of us will already be colonized with C. diff. So now, what prevents us from getting a C. diff infection? So what is the difference between asymptomatic colonization and clinical infection of C. diff? It is mainly, in simple words, it is a healthy microbiome. So what does a microbiome do? It builds up something known as colonization resistance. So because of the fact that you have healthy bacteria which are competing for nutrients, because of the fact that you have healthy bacteria which are secreting bacteriocins and certain such products, you are protected from a clinically you are protected from a clinical C. diff infection. So that is an important difference. Also, healthy acid levels. So all these things, normal immunoglobulins, all these things prevent an asymptom someone who has been colonized with C. diff from actually having a clinically significant C. diff infection. And when these factors start dwindling, so for example, if you start having the quality of the microbiome starts going down with antimicrobial usage, or you have someone who is immunocompromised, you have someone who is hypogamma-globulinic, all these protective barriers start fading away, or long-term acid suppression, and then the risk of C. diff actually increases. Now, antibiotics and C. diff has been talked about a lot. I don't think we practically need to really divide these into frequently associated or occasionally associated. The bottom line is that any antibiotic can increase the risk of C. diff, including the treatment of C. diff. So for example, if someone has empirically received vancomycin and metronidazole, vancomycin and metronidazole are not going to just go there and kill your C. diff organisms. There you will also have a collateral damage there. So a lot of the healthy anaerobes can also be destroyed, gram-positive organisms, which make up a huge part of the normal microbiome. These all can be affected. So that's why we need to be careful in giving empiric antimicrobial therapy for C. diff, especially in centers wherein you have C. diff testing available, and the report is just going to come 4 to 6 hours later. The patient is not showing any signs of fulminant C. diff. You can always wait for the testing report and then start therapy for C. diff if it's just a few hours away. And then immunocompromised patients, like I said, have special risk factors. So what is common to immunocompromised patients is the fact that they all have a lot of healthcare exposures, and they all receive a lot of antibiotics. But then there are certain specific risk factors. For example, our solid organ transplant patients. A lot of them will be on PPIs. They will also have, some of them will have post-transplant hypogammaglobulinemias. They may have received immunosuppressive therapy depending on the underlying disease. What about bone marrow transplant recipients? So again, antibiotics, healthcare exposures, prior chemos are going to be there. but colonization, mucositis, and the therapy used for mucositis, this is going to be a little bit more of a risk factor in our BMT recipients. Oncology patients, IBD patients also have their own risk factors. So, for example, radiation or the altered microbiome and immunosuppressive therapy. So, intestinal dysbiosis is a feature which is shared between C. diff and inflammatory bowel disease. So, all these factors mean that our immunocompromised patients actually can have certain unique risk factors when it comes to C. diff. So, this tells us, what happens to the microbiome, let's say during a process like a bone marrow transplant. So, look at what is happening to this patient before transplant and after transplant. So, if you see these bars here, you will see that before transplant, before the conditioning regimen starts, the microbiome is actually dominated by good bacteria. So, for example, these beneficial genus Bacteroides is dominating the microbiome pre-transplant. And once this patient goes through transplant, look at what is happening day plus 4, day plus 8, day plus 12. The good bacteria are actually dwindling and they are replaced by pathogenic bacteria. So, bacteria like Enterococcus or Klebsiella or E. coli, they are actually forming the bulk of the microbiome during the process of a bone marrow transplant. And this is known as intestinal domination. So, what is intestinal domination? If 30% of your microbiome is made up by a single organism, then that is called as intestinal domination. And normally, intestinal domination should be with beneficial bacteria. So, here what you see is that even the graph there shows that intestinal domination in this patient was with Enterococcus. And then there are studies which show that if there is increased intestinal domination at the time, especially when they haven't engrafted yet, they are neutropenic, then they are obviously at an increased risk of translocation from these bacteria. And that is partly one of the reasons why you get so many episodes of bacteremia. And especially if you look at our literature, you'll get mainly E. coli and Klebsiella in the pre-engraftment period. And one of the reasons is that all the microbiome can be dominated by these kind of pathogenic bacteria. So this really shows what goes on in a transplant recipient. If you look at the incidence of C. diff, then again, if it depends on the type of transplant. So, for example, multi-organ transplants, the risk is the highest. Lungs, again, the risk is high. Liver, the risk is high. Kidney traditionally has had a lower incidence of C. diff compared to other transplant recipients. And then you can imagine the factors behind that. It has a lot to do with immune suppression, the antimicrobial usage, and so on. BMT recipients, on the other hand, is clearly layered. So, if you look at global data, then usually you will find that the allogenic transplant recipients have a much higher risk than the autologous transplant recipients. Interestingly, what we found is that in our patients, so this was a study over 5 years, which included more than 300 transplant recipients that we recently published, and we found that autologous transplant recipients in our settings also had quite a high risk of C. diff, so which was higher than what was reported in the literature. Our incidence in the allogenic transplants or in the haploidentical transplants was comparable with the global literature, but autologous transplant patients had a much higher risk. That probably also reflects the antimicrobial practices in patients who are not that sick from a febrile neutropenia point of view. So, for example, a multiple myeloma patient who is having a fever may not necessarily always need antibiotics, and probably that reflects, because most of the autologous transplants are multiple myeloma patients and such diseases, not AML. So, that probably is also reflecting the kind of antimicrobial practices that there are in there are practiced in these patients. If you look at the clinical manifestations of C. diff, then asymptomatic individuals do not warrant screening for C. diff carriage. The main important feature there is watery diarrhea. So labs will often look at the consistency of stools. The labs will often look at the quality of the specimen even before accepting the specimen. C. diff is essentially a lower GI process, so you will very rarely find upper intestinal involvement or very rarely find vomiting. If you have these features, then it is probably reflecting another process that is going on. So, for example, if my BMT recipient is let's say having hematochezia, or he is having bloody bowel movements, or is also having vomiting, then there is a case to look for other things, including GVHD, other viruses, so many other differentials that can be there in these type of patients. Leukocytosis has been closely associated with C. diff. In fact, there are studies which show that leukocytosis can precede a clinically relevant episode of C. diff. So, an ICU patient who has received lots of antibiotics, we often get references for leukocytosis. If you really don't find any infective focus on your clinical examination, the patient is otherwise stable, I'm actually worried that in the next few days he might be developing C. diff if he hasn't developed it already. So, like I said, C. diff is essentially a lower GI process. Very rarely you will find the involvement outside the lower GI tract. And in some cases, the patients may progress to what is known as a fulminant C. diff. So this patient might develop signs of hypoperfusion. So there might be hypotension, septic shock, increased lactate levels. So this clinical entity is very, very important to recognize early on, because now in terms of therapy, we are almost doing away with differentiating between a mild C. diff, moderate C. diff, or a severe C. diff. What we are really interested in knowing is that is it a fulminant C. diff or a non-fulminant C. diff? Because for all non-fulminant C. diff episodes, the treatment virtually remains the same. So clinically, you may not get much by differentiating between what is a mild C. diff versus a severe C. diff. But these type of severity scores have been used for a long time. So a lot of these scores take into account the albumin levels or the creatinine levels or leukocytosis or pseudomembrane formation. Now, none of these models have been validated. Atlas perhaps is the closest to validation. But these models have to be used with a pinch of salt, because it really depends on the underlying host that you're dealing with. So, for example, if I have a BMT recipient who has developed C. diff, is neutropenic to begin with, maybe he has low albumin to begin with, lower creatinine levels to begin with, then it really becomes difficult to interpret the ZAR score in this kind of a setting. So there are experts who believe that we should not be actually stratifying these patients from a severity point of view based on these scoring systems. So again, there are studies which also, for look at this study for example here, patients with hematological malignancies had lower creatinine levels and WBC counts. And look at this study, again, small study, but pseudomembrane formation was not detected in any of these patients on immunosuppressive agents. So that's why traditional scoring systems which look at WBC counts or creatinine, so they have to be interpreted in accordance with the baseline characteristics that are there in these type of patients. And that's why, at least in BMT recipients or in a lot of our immunocompromised patients, severity scores may not help us much. So this was a patient with AML with neutropenic fever. His C. diff GDH antigen is positive, but toxin is negative. So what can be done here? So the first important thing is that why was C. diff sent? Was C. diff sent because it was a clinically compatible picture? So for example, if this patient is, let's say, having 2 to 3 semi-solid motions and C. diff was sent and GDH antigen is positive, your pre-test probability of C. diff to begin with is on the lower side. Whereas if this was a patient who is having 6 to 7 watery bowel movements, greenish, foul smelling, then your pre-test probability is higher to begin with. So that is very, very important to clinically try and gauge the pre-test probability of C. diff. A GDH antigen positive and a toxin which is negative could either indicate just colonization with C. diff, or it could indicate a false negative toxin. So we'll look at this. So what are the tests that we have to diagnose C. diff? A lot of labs will start with, so there is a two-step process. A lot of labs will start with the GDH antigen. So this GDH antigen is very, very sensitive, but just the presence of GDH antigen does not indicate a C. diff associated diarrhea. So what can happen is that asymptomatic colonizers can still have a GDH antigen which is positive. So it's easy to perform, it's highly sensitive, but it is not diagnostic or confirmatory for C. diff. Whereas if you look at the toxin immunoassays, these toxin immunoassays actually, quantitative or qualitative, look at the amount of toxin that is produced by the C. diff organism, and that's why their specificity is good. So which means that if you have a GDH positive and a toxin assay which is positive, then it is confirmatory for C. diff, but their sensitivity can be on the lower side, especially in immunocompromised patients. There are studies which suggest that the sensitivity of these toxin assays can be on the lower side. The other problem is that the amount of toxin produced sometimes can be lower than the lower limit of detection of these assays. So for example, if your assay is, let's say, detecting 6 picograms of toxin, and if your patient is producing 3 or the C. diff there is producing lower than that, then your toxin assay can be falsely negative. Again, most immunocompetent patients with such minute amounts of toxin can actually get over C. diff on their own. But in our immunocompromised patients, toxin neutralizing antibodies are also not the best. So that's why a very small amount of toxin can still bother your immunocompromised patients. So that's why in immunocompromised patients, a GDH which is positive but toxin which is negative, in the clinically compatible setting, you can't dismiss it just as a colonization. You need to think harder about it. Whereas PCR, so if you are starting with the PCR tests are very, very sensitive. They also detect this TCD-A and TCD-B genes. But remember, these are not diagnostic of actual toxin production. It just tells you that it is a toxigenic strain. It doesn't actually measure the toxin production there. So what is the utility of PCRs? Negative PCRs can definitely rule out clinically significant C. diff, but a positive PCR can still mean colonization, But here it means colonization with a toxigenic strain. That is the additional information that a PCR is giving you. And there are toxigenic cultures for C. diff, so which are actually very, very good but very, very cumbersome to perform. And what is the additional advantage there? It allows you antimicrobial susceptibility testing, which I feel is increasingly important in C. diff. But of course, the access to that in clinical practice remains very, very limited. And then there are neutralization assays, so they are not as sensitive as the toxigenic cultures, but they have very, very high specificity. So this can be used as an algorithm for our C. diff patients. So if you're starting with the GDH antigen, if your GDH antigen is positive and toxin is positive, there is no doubt that this is C. diff. So any one toxin positive or both toxins positive doesn't matter. As long as you have at least one toxin positive and GDH is positive, there is no doubt that this is C. diff. If both are negative, which means both steps are negative, GDH antigen is also negative and toxin production is also negative, then there is no doubt that this is not C. diff. What is a gray zone is a GDH antigen which is positive but toxin which is negative, the kind of patient that we talked about. So here what we have to do is first think of the pre-test probability of C. diff. And if you have access to PCRs, PCRs can be used as a rule out test for C. diff, not a rule in test. So in this kind of a situation wherein you have a GDH which is positive but toxin which is negative, and you send a PCR test, if PCR is negative, you need not worry about C. diff. But if PCR is positive, then this either can mean colonization with a toxigenic strain or it can mean clinically relevant C. diff. So we have had plenty of situations in which GDH is positive, toxin is negative, we send out the PCR. By the time the PCR comes back, the PCR is positive, but the patient's diarrhea has resolved. So here it is unlikely, that this was C. diff. So you take it as colonization with a toxigenic strain. Of course, you are clinically still trying to monitor this patient closely, but you may not necessarily jump and treat this patient. Whereas if you have a high pre-test probability and if your PCR comes back as positive and clinically it is fitting, then you might treat an immunocompromised patient who has a GDH positive, toxin negative, but a PCR positive. Whereas if you start with a PCR first, then you don't have another test to fall back on. So for example, if you start with a PCR and if the toxins are positive, there's no doubt. But if you end up in a gray zone with a PCR, so for example, a PCR is positive, but a toxin is negative, then you can't go back and test the GDH antigen. That doesn't make sense. So what you can do is just look at the pre-test probability of this picture and then try and decide whether this needs to be treated or not. So remember, a PCR can be used to rule out C. diff, not to rule in C. diff. A negative PCR is equal to the patient not having C. diff. A positive PCR still means either colonization with a toxigenic strain or clinically relevant C. diff. Then there are certain other caveats which are important. So do not perform repeat testing routinely within 7 days of the same episode of diarrhea if the initial test is negative. The reason is that the sensitivity of this test doesn't increase too much if clinically the picture hasn't changed. So for example, if your patient was maybe having 3 or 4 watery movements and after 5 days he's having 15 bowel movements which are watery, then maybe there is some merit in repeating the assay there. But if the clinical picture has remained the same, then again sending another test may not increase the sensitivity of the test. Repeat testing may be considered in patients who have a worsening clinical picture. Do not test for screening asymptomatic carriers. Episodes of recurrent C. diff should be assessed by repeat testing because it means that the first episode had resolved. No value in testing to establish cure. This is very, very important, especially in patients in whom multiple differentials are being considered. So for example, I have a BMT recipient, let's say he's 4 weeks from an allogenic transplant, develops diarrhea, we send a C. diff assay, C. diff is positive. Let's say you start this patient on oral vancomycin. Day 4 or day 5, he continues to have diarrhea. So what are the possibilities here? One is that this could be vancomycin refractory C. diff. The other is that we have missed another etiology in this patient because these patients often can have multiple reasons for the diarrhea. So is there another something like GVHD? Is there CMV colitis? Is there any other viral colitis going on? So at that point of time, if you send a repeat assay, the repeat assay is not going to help you too much. So the decision to whether you need to look for additional etiologies doesn't really depend on the repeat assay. It's essentially a clinical decision of trying to determine whether this is C. diff which is refractory to vancomycin versus looking for other etiologies. And knowing your host is extraordinarily important in this type of a situation. So there is no value in testing to establish cure. So that is very, very important. So this is the study which looked at the sensitivity of the toxin assays and found that patients who are immunocompromised, so who are on steroids or who are neutropenic, they may not have very high sensitivities for the assays. And That is what we factor in while building the algorithm in immunocompromised patients. So with this, let's look at the treatment of C. diff in our settings. So initial episode, non-severe. So like I said, we are increasingly doing away with the severity scoring systems for C. diff because they are not very accurate when it comes to stratifying the patients. So initial episode, non-severe. The guidelines recommend fidaxomicin because it's a narrow spectrum drug. Like I mentioned in the beginning of my talk, there is some collateral damage with C. diff drugs. Perhaps it's the least with fidaxomicin because it's a narrow spectrum drug, and it's also considered to be sidal. So guidelines will recommend initial therapy with fidaxomicin. Also, the recurrence rates with fidaxomicin have been found to be lower than the other agents. It's difficult to get fidaxomicin routinely in our practice, and in India also we don't get the 125 milligrams preparation. So most of the patients in our settings are around 250 milligrams every 6 hours. So this type of a regimen really generates very high intracolonic vancomycin levels. So usually, with this type of a regimen, most patients will not be underdosed unless they have a very high frequency of diarrhea. So which means that if they have maybe like 20, 25, 30 bowel movements in the day, then you might want to think that this is slight underdosing. But in most 99.9% of the patients, the levels that are attained intracolonic or within the lumen of the colon, the concentration of vancomycin that is attained is reasonably high with this type of a dose. There is some concern with vancomycin refractory C. diff or vancomycin resistant C. diff. So if you look at different studies from different parts of the world, then you will see that there is some amount of resistance to vancomycin, and which means that do we look for alternative agents in C. diff? So this was a study which was published which compared vancomycin versus teicoplanin. Of course, these are not all vancomycin resistant patients, but this is just upfront using teicoplanin versus vancomycin, and you can see that the results are pretty comparable, maybe slightly better in the teicoplanin arm, not statistically significant. Even in our settings, we have had a pretty good experience with oral teicoplanin. So usually, I don't start with oral teicoplanin. I'll use it only in the setting of C. diff, which is refractory to vancomycin. But in the retrospective experience that I was talking about, the patients who were started on oral vancomycin versus the patients who were started on oral teicoplanin, mainly by the hemat team. Like I said, in my personal practice, I will not start a patient on oral teicoplanin upfront, but the rates of refractory C. diff were lower in the oral teicoplanin group. So again, these are about 50 patients, but it does show that teicoplanin can be a good alternative drug or can be used when it is vancomycin refractory. This is one of the drugs which can be tried. What about severe C. diff? Like I said, the management doesn't change much. What you really need to look for is that are there any constraints as far as vancomycin reaching the site of infection is concerned, which means that do you have any ileus, or do you have a patient who is unable to swallow, who is vomiting a lot because of other reasons in these type of situations. Because in severe C. diff, again, it is important to maintain good levels in the colon of vancomycin. So what you are looking for is that are there any factors which will make my vancomycin not reach the site of infection properly. If that is so, then you may need to use something like a nasogastric tube or giving a vancomycin rectal enema. Coming to fulminant C. diff, that is where the drug management changes a little bit. So this is one area wherein an additional IV agent has been recommended. So how do we define fulminant C. diff? Ideally, you want to recognize fulminant C. diff in the pre-fulminant phase. So anytime your C. diff patient starts developing signs of hypoperfusion, so these are the kind of patients in whom you want to measure the abdominal girth frequently in the day. If there is an increased abdominal girth, signs of ileus, initial signs of shock, increased lactates, hypoperfusion. So these are the kind of patients who are likely to develop full-blown fulminant C. diff colitis, and these are the worrisome patients. So there, an additional IV agent will be recommended. There are two options. One is IV metronidazole. The other is IV tigecycline, which has increasingly good data for fulminant or severe C. diff. So tigecycline is not something that you would use for mild to moderate or even severe episodes upfront as monotherapy. Usually, it is a drug which is reserved for fulminant episodes as a part of combination regimens. And that's also the time to think of other things. So whether this patient needs a surgical consultation, a rescue FMT is much easier said than done in our settings because we don't have preformed stool capsules. So it is very difficult to get a rescue FMT done in our setting. So let's say you have a patient who has a fulminant C. diff who is not responding to medical management. It will take a lot of planning in our setting to do an FMT. It takes at least 5 to 7 days. I'll come to the FMT experience, but takes a long time in our settings to actually plan a rescue FMT. So tigecycline can be considered as a potential therapeutic option, especially in severe or fulminant cases. There's a meta-analysis which shows cure rates of about 80%. So again, not a drug which you will use upfront, but something that can be used as a part of a combination regimen. And recurrent C. diff again can be a problem. We've had this problem quite a bit in our BMT recipients. So you have medical options there, and then you can do an FMT. But essentially, what it means is that the drug that worked on the during the first episode can be retried with longer durations. Second or subsequent recurrences, you need to start thinking about an FMT. So that brings us to when would you consider FMT for C. diff? So patients with third or more recurrence, although there are now studies which are looking at FMT during the first recurrence itself, and there are studies which are also looking at FMT as the initial therapy for C. diff. And severe complicated fulminant refractory rescue FMT. So like I said, rescue FMT is much easier said than done in our settings. So in India, the main challenge when it comes to FMT is looking for the donor or screening the donor, because we don't have preformed stool capsules, we don't have stool banks unlike in the Western world. So it becomes difficult to choose a donor. There is also quite a bit of financial resources which need to be used for screening these donors, because if you get, let's say, biofires or PCR tests on each and every donor and require 3 to 4 people to be screened for every FMT, then easily the cost of screening goes up to 1 lakh, because if you're doing biofires, all these tests for all those 3, 4, 5 potential donors, then it becomes difficult. These are the mandatory tests that we perform in our hospital as far as donors are concerned. So they should be off immunosuppressive therapy, chemotherapy, antibiotics, or PPIs. That's obvious. Look at their family histories, clinical conditions, and all these things need to be taken into account. And then doing a basic screening in terms of the CRP, HIV, syphilis testing, Hep C, and all. And then doing stool examinations, modified ZN staining, C. diff assays, cultures, and then trying to decide who is a good donor, because donor screening can be challenging in our settings. We've had several experiences with donors. Few of our donors have turned out to have asymptomatic C. diff colonization. One donor had an NDM producing E. coli. So there can be various experiences in our settings. A completely healthy person who has never been to any of the hospital settings, young 20-year-old guy. So these are things that we need to be careful about, because the last thing that you want to do is introduce carbapenem resistant organisms via an FMT. And then once you have selected the donor thoroughly, what can be done is that a freshly voided sample needs to be submitted to the lab, and the lab can then sort of process it and make an emulsion, and this can be used by the gastroenterologist to do an endoscopic FMT. So there are two options there: a lower GI approach and an upper GI approach. So it can be administered via lower GI or an upper GI approach. They are generally comparable. There are other factors that you would take into account. For example, if there is any other disease at any other site, especially if this patient has a GVHD and so on. So lower GI administration has been found to be slightly more effective when the colonoscopic spraying is there. Maybe it has something to do with the fact that the site of C. diff itself is the lower GI tract. Stool banks serve as a source of capsules prepared from screen donors in some areas, but we don't have the luxury. The important thing there is peri-procedural cessation of antibiotics. So antibacterials need to be definitely stopped. Whether antifungals and antivirals need to be stopped in the setting of FMT still is debatable. So that brings us to this question, what is the contribution of fungi to the microbiome? So most centers usually will not have it in their protocol to stop prophylactic antibiotics, because when we have C. diff with GVHD, these patients usually will be on prophylactic antibiotics. Prophylactic antifungals. So that's why usually in our settings, we don't stop the prophylactic antifungals. The protocols for donor selection need to be robust. So we need to screen quite a few donors. Usually in our settings, we need to screen at least 3 to 4 healthy people in order to get one FMT done. Of course, if we find a good donor, we tend to hang on to him till he gets bored of donating, because we have had one donor donate for at least 3 or 4 of our FMTs in 1 year, but then these people disappear because they are not going to do this day in and day out. So we try to hang on to them, but finding a good donor is kind of challenging. And ideally, what needs to be done is also a microbiome analysis, but that really adds to the cost, and you also need to have a reliable lab to perform those sort of studies. We have done 2 installations of FMT. So if you look at the data, then sustained cure is usually from 2 installations of FMT. So if you do 2 installations, the cure rates go up to around 80 to 90% compared to 50 to 60% with one installation. And this was the initial experience that we published maybe 2 or 3 years back. Now there have been several more FMTs done in our center, but the outcomes looked decent. Luckily, we haven't really had episodes of bacteremia after C. diff. We've had one patient who developed CMV, but not a lot of not any. We haven't had any episodes of bacteremia or fungemia in the immediate post FMT period. And then if you look at, like I said, these preformed stool capsules, they are very, very convenient and comfortable to use. Also, the time between thinking about an FMT and actually administering an FMT can be reduced considerably if you use stool capsules, but we don't have the luxury of that. So I'll summarize by saying that C. diff is an important problem in our settings. I showed you our own transplant data, so it's an important problem. A two-step approach to diagnosis is recommended. So if you start with the GDH antigen, if the GDH is positive and toxin is negative, you can perform a PCR and look at the PCR results and pretest probability. Regarding the PCR, like we said, a positive PCR can be used to consider C. diff, but it doesn't establish the diagnosis of C. diff. A negative PCR is what can be used to rule out C. diff. So PCR is not a rule-in test; it's a rule-out test. C. diff in immunocompromised patients has many different aspects. The severity scores may not apply. You can have other etiologies that can confound the clinical picture. Management can be challenging. There are constraints. We don't have easy access to fidaxomicin. We have just one strength of vancomycin as our preparation. We can have vancomycin refractory C. diff. Luckily, we have the luxury of drugs like oral teicoplanin. You need to look out for signs of fulminant C. diff, and if there are early signs of fulminant C. diff, adding another IV drug upfront makes sense. FMT as a modality is emerging. It is challenging, but it is doable in India. It is challenging because cost effectiveness, careful selection of the donor, and also in the absence of good microbiome studies routinely, making sure that effective FMTs are done. I think that is also a very, very big challenge. So I think I'll stop here. If there are any questions, I'll be happy to take them. Yes.
Sir, I understand that C. diff is a part of antibiotic-associated diarrhea. So, when a patient in the ICU on antibiotics develop diarrhea, how will you approach, and how will we distinguish, and what's the difference in the management? C. diff you have already explained, but if it's just an antibiotic-associated diarrhea.
Right. So, and diarrhea in the ICU can have many, many differentials. In fact, if you look at diarrhea in the ICU studies, then majority of those causes are actually non-infectious than infectious. So the first thing that you wouldn't want to do is start these patients empirically on metronidazole. The other thing is that, if you're looking at C. diff, you are looking at the clinical characteristics of the diarrhea. Usually 99% of the times, the C. diff diarrhea will be watery and will have at least 3 to 4 bowel movements in the day. And testing is the key. Like I said, empirically treat. I'm not in big favor of empirically treating for C. diff unless you really have any signs of fulminant C. diff there, because like I said, empiric therapy also can be a problem. So one thing is not just because in the ICU we find so many patients on metronidazole or fluoroquinolones when diarrhea develops. That is really not the answer to 99% of the diarrheas in our ICU setting. So I think looking at the etiologies, looking at non-infectious causes, which in literature actually dominate over infectious causes in the ICU. And if you're thinking of C. diff, having access to testing, I think those are important things.
So what's the role of probiotics there? Pre.
So, probiotics, personally, I don't use probiotics. There are enough concerns with probiotics regarding episodes of fungemia or episodes of bacteremia. The literature is not very robust. Like teicoplanin can affect gut microbiome less than vancomycin, so we expect less relapses. But how are they using? Like, what is the biological possibility of teicoplanin being effective in C. diff, which is refractory to the treatment with vancomycin? Yes. So C. diff resistance mechanisms are not yet fully explored. There are various aspects there. VAN could be one part of it, but Muir mediated resistance could be one part of it. So there are differences there. teicoplanin, like you said, should affect the microbiome less, but that's also not fully studied. The relapse rates with teicoplanin are also not studied. In our experience, the relapse rates have been lower, but definitely we have found utility upfront. The other group of patients wherein teicoplanin can be useful is those who really have a lot of profuse vomiting, difficulty in swallowing vancomycin, because teicoplanin can be easily administered as an oral solution. So those kind of things are important for. So there are no studies which have looked at growing C. diff, looking at the MICs of vancomycin and then using teicoplanin in the setting of resistant C. diff. So most of the studies there are refractory C. diff, but a refractory C. diff always may not mean that it is a resistant strain there. So like I said, in the diagnosis, if especially if you're looking at immunocompromised patients, pseudomembrane formation will not be there in all your patients. The toxin assays and especially the GDH antigen that has such high sensitivity that routinely we do not require to look at the histopathological picture.
How do you make a teicoplanin solution actually? You're making your own solution?
Yes. So the teicoplanin powder that you get, you can put it in about 10 to 20 ml of sterile water and make the patient drink that. So we usually use 200 milligrams per 10 to 20 ml BD.
Any other questions? Thank you.
Thank you, sir, for your insightful presentation. Our next talk is on managing difficult to treat lactose fermenters, ESBL, CRE, and MDR enterobacterials. Now I invite Dr. Rajiv Soman, consultant in infectious disease and a fellow of Infectious Disease Society of America, co-chairman of the Fungal Infection Study Forum, a founding and executive member of the Clinical Infectious Disease Society and editor in chief of its official journal. Sir, please.
It's not working, no? Because we're running short of time, there will be no tea break. I'm sorry for that. So tea is arranged outside. Those who want to have tea can have a cup of tea and join us back. There will be no dedicated tea break. Good morning. Thanks, Dr. Jacob, and everyone here at Caritas for this opportunity. Lovely conference, excellent participation, audience, and everything else. Hospitality, what else? Okay, so I'm tasked with talking about the uh, fermenters or enterobacterialis. And do we have anything new or in the current climate of great amount of resistance? Okay, so if the devil were to grant you a wish about gram negative resistance, what would you wish for? ESBL? That's what I think. We should be wishing for ESBL rather than CREs and all the other things. But remember that that was only the first step in the slippery slope of the loss of antibiotics. What happens here is that the resistance determinant is selected in an environment of heavy antimicrobial use, and it is transmitted by the so-called internet of the bacterial populations far and wide. And we are really locked in a seesaw battle with the microbes. So every time we have a new drug, we think we are winning, and then a new mechanism of resistance comes up, which is a recipe for a disaster of lot of pharmaceutical effort. Needless to say, we must know this enzymology well. And today, as ID physicians and even critical care and even internal medicine people, we have to know about all this ESBL, AMC, OXA48, and various other OXAs, NDM, PVP insertions, and various types of PVP insertions, and so on. So that's why I made in the red the graph or the bar of AMR, which is so large. Comparatively, our diagnostics much less, and therapeutics absolutely near the ground. Okay, so we really have to cover a lot of ground. So let's begin with the ESBL. This was a long time ago that we first published this outcome of treating ESBL infections with carbapenems versus non-carbapenem antimicrobials. Needless to say, this was not a proper randomized RCT, just an observational study. And what we found is it was possible to treat at least the less serious ESBL infections with non-carbapenems, which we thought will not compromise outcomes, but will likely result in restricting the use of carbapenems and may help preserve their utility against increasingly resistant organisms. Okay, but this did not happen. And then came this trial called Merino trial, which sort of laid this controversy to rest, attempted at least. And in this, they found that there was a superiority of meropenem versus piperacillin tazobactam in terms of 30-day mortality for patients with E. coli, Klebsiella bloodstream infections, which were ESBL producers. Right, but despite the publication of this trial, this debate on whether it should be BLBLI or carbapenems continues to date even now. And this was some evidence which has come up recently in 2025. So carbapenem resistant Enterobacterialis acquisition following pip-tazo versus carbapenem treatment. So this was a propensity matched cohort study from a single center in Israel and done over, I think, 13-14 years. We showed that the risk of acquiring CRE after using a carbapenem was much less with pip-tazo as compared to using a carbapenem in a CRE endemic setting. So how would I look at it? So I would still consider using a BL-BLI in preference to a carbapenem if it is a mild to moderate disease, if the patient is immune competent, if the site of infection is a urine or a surgical skin soft tissue infection, intra-abdominal infection, who has undergone proper source control. On the other hand, if it is a bloodstream infection, it is pneumonia or much more serious infection, I would not like to use the BL-BLI. This to some extent is dated, but if you have an organism such as Klebsiella or maybe Enterobacter which might actually start producing AMC or something like that, I might not want to use a BL-BLI. Another good idea is to look at the pip-tazo MIC. If that MIC is really low, that is, it is like less than 8, then maybe I can use pip-tazo there. On the other hand, if it is more than 16, considering the UCAS breakpoint, then it might be better to avoid the BL-BLI. Even if I'm choosing to use the BL-BLI, remember always to use at a high dose, and often the dose recommended is pip-tazo 6 hourly and plus prolonged infusions. And certainly you can use this BL-BLI for de-escalation, which has not been looked at in any particular trial. I'll move on quickly to AMC. So this is a 55-year-old male patient who has a HCC and a chronic liver disease with portal vein thrombosis. He's being considered for liver transplantation. Look at this. He has Enterobacter cloacae bacteremia, and this is its susceptibility. So it is reported as susceptible to cefuroxime, ciprofloxacin, and imipenem. So this patient was being treated with cefuroxime in keeping with stewardship, but he didn't respond. He had unremitting fever, and with this he was referred for an ID opinion. So should I not responding? So should I escalate this to imipenem? and then again de-escalate to cefuroxime, something like de-escalation. We always want to do that. So do you think that's a good idea? No, because this organism is Enterobacter cloacae. So we have to, now this is how I can rate the Enterobacterialis. Remember, it is only for Enterobacterialis. So which are the organisms which has the highest propensity to produce the MC? So it is Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter fruendiae. And then much less are the other ones which I have shown in black. So this is Serratia and Morganella the least. Now look at which drugs have the propensity to induce the MC. So again, it is highest with ampicillin, first, second generation cephalosporins, imipenem, and it is much less with piptazo or with piperacillin itself or with cefepime. Now the next question is, after having induced that MC, is the drug susceptible or does that drug itself get destroyed? Okay, so what is its stability to the MC? So again, these drugs, which are also good inducers, are also unstable, means they will get destroyed with the MC, and therefore it might not be a good idea at all to induce MC with imipenem and then take it out and throw cefuroxime to the dogs. So now you have induced MC and now you are using cefuroxime, which will completely destroy it. Okay, so that strategy would not be a good idea. So as I said, these are the organisms are the most problematic. Although maybe piperacillin, piptazo, and cefepime may not be bad in this particular situation, but whenever possible, look at non beta-lactam alternatives. So interestingly, this patient was susceptible, the bug was susceptible to ciprofloxacin. So if you can use an aminoglycoside, we would not like to use that in this patient. He's got chronic liver disease, almost end-stage renal disease. You will not like to use tigecycline. I think that was also susceptible, obviously, because this is bacteremia. And so you could use actually fluoroquinolone like ciprofloxacin. Now let's move to the next enzyme of interest. And this is a patient of CA esophagus. He was operated for resection and anastomosis. He had leakage, mediastinitis, and empyema, as you can see. Now this is what has grown from that empyema culture. So this is E. coli, and you will notice here that it is ertapenem resistant, imipenem resistant, meropenem intermediate with a MIC of 2. So what do you think might be the resistance mechanism here? Would it be OXA48 plus NDM or OXA48 alone or efflux or NDM alone? Any quick answers? So meropenem is 2, intermediate, and ertapenem and imipenem are resistant. Any microbiologists here? Okay. You have to choose only from this. Okay. Right. Yeah, in India it is Oxide 181 most of it. Correct. Correct. So this is likely to be OXA 48 alone. See, the idea is like this, that when you have NDM, NDM is a very strong carbapenemase. So it usually confers resistance to all the carbapenems. So very likely this is OXA 48, or like Parikshit said, 181 is the one which is, see, we always say OXA 48 like. So it is 181 which is there in India. So efflux may not be the right answer because that confers resistance to meropenem rather than to imipenem, and like I said, NDM alone confers resistance to all the carbapenems. So what is the importance of this? Okay, so this was done then, rapid carbar was done, and that showed that it is only OXA 48 or OXA 48 like. And then the disc elution was also done, which showed that ceftazidime avibactam was susceptible. So this patient can be treated with Cas-Avi without aztreonam. So remember, this is a patient with liver disease, and aztreonam high doses can be perhaps potentially hepatotoxic. So it's a good idea not only in terms of stewardship, but to avoid a drug which might be potentially toxic. Now, what happens when you have OXA48 and NDM? So let's take this patient. This is a 40-year-old, again, alcoholic liver disease, end-stage liver disease, awaiting transplant. He has had multiple hospitalizations before. He has fever, ascites, and as you can see, huge collaterals, portasystemic collaterals. He has bacteremia due to CR E. coli now. All the blood cultures are positive. And this is its susceptibility pattern. So what do you think should be used? It is reported as susceptible to aminoglycosides, tigecycline, fosfomycin also. So what do you think should be used for this patient? Any ideas? Okay, let's look at each one of these. So as I said, aminoglycoside again seems to be incorrect, although it is reported as susceptible because he is at a heightened risk of nephrotoxicity. Again, tigecycline, similar to the previous patient, is incorrect. It's not a preferred drug for bacteremia. Now, fosfomycin you could use potentially, but it will have to be it can be a problem because there is a huge amount of sodium overload with that, and this patient is prone to get hypo volume retention as well as hypokalemia. So, and also if you use it alone, then resistance may develop very quickly. So none of the above seems to be the right answer. So what is this? What do you want to do then? You need further testing to indicate whether cas-avibactam or aztreonam avibactam will be effective. So expert karma R was done for this particular patient, and again that showed that there is NDM there. None of the other determinants are present. And then this is the broad disc elution method. We showed that there is synergy between cas-avibactam. So what is likely here? The MIC of aztreonam avibactam must be less than 6. Vyric and CMY 42-145 must be present. So this is the enzymology which I was talking about. So today we need to know all this very well. Virin is absent. All this must be Greek and Latin to you, but we'll have to know all this, or none of the above. Any thoughts? So the only correct answer here is MIC is less than 6 because that is the final concentration of aztreonam in the presence of avibactam, which is what you get in that tube. So this is the right answer. So this is not going to give you the actual MIC, but it just tells you that it is going to be less than 6. Now why not the others? So a little bit of this. So Vyric as well as this CMY 42-145, they increase the MICs to more than 16. So it's going to be highly resistant. So these are the PVP3 inserts. Remember, this organism is E. coli and it is an NDM producer. So very likely it has PVP3 inserts. But there is a difference among the PVP3 inserts. So some of them can raise the MICs a lot, whereas others do not. So in this patient, we have an MIC which is less than 6. So it about maybe Virin, which does not increase the MIC much, may or may not be present. So there is one more way to look at the actual MIC here, and this is by the E-test method. And here we have a MIC of aztreonam avibactam of 2. Okay. So now what dosing should be used? So it is decided to use aztreonam avibactam or ceftazidime avibactam or plus aztreonam in this particular patient. So what do you think would be the best way to dose in this particular patient? So I'm not going to read out all this. You are going to check whether this is the latest recommendation or this is something which you think we can use because we have both the drugs available from generic manufacturers, or was this the old one which we used to use? So ceftazidime avibactam 2.5 plus aztreonam 2 3 times a day. Okay, so the currently favored regimen is this, and let's see what is the evidence base for that. So from experimental studies, this is what we call as a joint PK/PD target. Okay, the joint PK/PD target, because here you have the inhibitor and you have a drug which is going to be effective only in the presence of the inhibitor. So unless both the levels of these two drugs, both levels are good, it's not going to be effective. So that's why we call it as a joint probability of target attainment. So what was selected for clinical success, and remember this is from experimental studies, was 60% free time over MIC of 8 for aztreonam. And where did we get this 8 from? Because that was the nominal MIC when aztreonam and avibactam were there together. Plus 50% free time over the concentration threshold. Parikshit explained yesterday that for the BLI, it is not MIC, obviously, it is the concentration threshold. So that should be more than 2.5. So this was established from experimental studies. Then they worked out various different regimens and found out which of these regimens has success in attaining this particular target. So this particular regimen has a joint probability of target attainment of greater than 90% and had a very high Cmax as compared to other dosing methods. So this particular regimen is expected to work very well for isolates even with a MIC of 8. So certainly it will work very well for isolates whose MICs are less than 4, which is the actual breakpoint proposed by both UCAST and CLSI. And then if you look at this particular patient, its actual MIC of aztreonam avibactam is only 2. So it will work beautifully well for this particular patient. In fact, this will have a PK/PD index of 60% free time above 4 times MIC. Okay, the measured MIC is 2 in this particular patient. Now, what is so magical about this 4 times MIC? It is the index which can suppress resistance, okay, and prevent the selection of resistant subpopulation. So if you can really have an MIC which is 2 or less than that, then this regimen will work very well. It will not even generate resistance. So what are the messages from this case? The currently recommended dosing is expected to achieve more than 90% joint probability of target attainment, which can really translate to good clinical outcomes. Nevertheless, you need loading doses for that, for achieving this target early in the day. And early in the day is really very important. You know, yesterday we had a little discussion that whatever you want to do it in the first few hours. Don't save your best doses or your best drugs for the grave or something like that, they say sometimes. And where do you want this? Especially in those who are critically ill, which you guys are going to look at every day, those who have augmented renal clearance. And actually, they did Monte Carlo simulation studies which showed that even with augmented renal clearance, this was still a little above 90% achievement. And also for intra-abdominal infections. And as I said, that if the actual aztreonam avibactam MIC is checked and found to be below 2, you can have a very, very good index. Now look at what we have here, and this comes from CMC and Balaji's work. So you have E. coli here, and you have Klebsiella pneumoniae here. Okay, and you have aztreonam avibactam working beautifully, 99.6% for Klebsiella, but for E. coli it works about 70 or 67% time. So this is the problem here with the penicillin binding protein inserts. Okay, and some of them can be bad, like we discussed, and therefore it is, especially for E. coli, it is very important to show this synergy. And preferably if you are doing the E test and you actually get a full coat or MIC, it is going to be very, very useful. Some of the others, cefiderocol, you will notice here is not, really going to be great news in our country looking at this susceptibility pattern. Cefepime nacubactam seems to be good. This doesn't seem to be good. Sulbactam, durlobactam may work for the E. coli, but yet to be tested for this. And cefepime-zidibactam again seems to be the rising star which we are really anticipating. So I'll close actually before time, but doesn't matter. So CR enterobacterialis have truly become nightmare pathogens, and new resistance mechanisms are being discovered every week, if not every day. And organisms frequently have a combination of both old and new mechanisms. So all of us really need to be updated on this kind of enzymology. So, our knowledge, the diagnostics, as well as therapeutics, have to keep pace with all these. These are basically forces of nature. These bugs are just there in everybody's bowel, and every day we are bombarding them with so much of antibiotics. So, naturally, this is a force of nature, and we are really against that something unstoppable sort of force of nature, and therefore, there is no place for complacency. With this, I'll stop here and if there are any questions, comments, I'll be happy to take. Tea break looks like.
Thank you, sir, for your valuable insights.
Where did you put that?
We now invite Dr. Parishit Prayak to speak on Pseudomonas and Acinetobacter, managing difficult to treat non-fermenters. Sir, please.
Should we start? Okay, so good morning once again. I'm going to be talking about approach to carbapenem resistant Pseudomonas and Acinetobacter infections. So in the session before this, sir talked about the enterobacterial enzymes. We looked at OXA48, NDMs, we looked at AMCs, ESBLs like CTXM. So let's try and see what the important enzymes are as far as Pseudomonas and Acinetobacter is concerned. As we all know, there are four basic ways in which a gram-negative organism can become resistant to a beta-lactam antibiotic. One would be modification of this porin channels here, wherein your beta-lactam is unable to enter, or you could have beta-lactamases, which we saw in the earlier session, the enterobacterial beta-lactamases, and we'll see the Pseudomonas and Acinetobacter beta-lactamases. Then you could have modifications of PVPs, so talked about that in one of his cases, or you could have efflux pumps, which are going to kick your beta-lactam antibiotic out. So let's talk about Pseudomonas aeruginosa, and let's talk about the important enzymes that we have. So just like when we think of E. coli or Klebsiella, we think of CTXM or SHV or TEMS as their ESBLs. Rarely we think of KPC as the carbapenemase, and definitely we think of NDM OXA48 as the major carbapenemases in our settings, which are the important enzymes when it comes to Pseudomonas. So KPC, yes, but again, rare in our settings. Most of the KPC literature comes from the Western world. In the US, majority of the carbapenem resistance for Pseudomonas is either through KPCs or through non-enzymatic mechanisms. But our problems are a little different. Then we have class B carbapenemases there, NDM, WIM and IMP, and not to forget the WIM and IMP, which are also very, very important in the setting of Pseudomonas. You could have JES. I'll show JES in one of the cases later on. So JES is also an important enzyme. The problem with JES is that there are two problems actually, that not all JESs are carbapenemases, which is not a problem but which is a peculiarity. But the other thing is that the inhibition of JES even by avibactam is not 100%. So there are some JES variants which can escape actually the inhibitory properties of or inhibitory mechanism of avibactam. So JES can be a problem when it's thrown in to the picture with other enzymes. Then PER and Web are important enzymes of, these are class A enzymes of Pseudomonas. They are a little peculiar. So just like we have CTXM, SHV and TEM for our E. coli Klebsiella, you could have PER and Web. Again, the inhibition by the currently available BLIs is very, very poor. In fact, if you look at the studies, maybe apart from Relibactam, for most other BLIs, including Tazobactam or Enmetazobactam, the PER Web inhibition is not up to the mark. So if you have PER and Web in there, then it becomes a problem because they are going to destroy your Astronam, which you use for the NDM producers, and you're not going to be left with a lot of options as far as BLIs are concerned to take care of these PERs and webs. And then AMC Pseudomonas can definitely have AMCs, and some of the AMC variants can also be a problem. Beyond this, Pseudomonas can have non-enzymatic mechanisms. So there could be efflux, porin mutations. But before that, let's try and see which enzymatic variants can be a problem as far as avibactam is concerned. Because if this wouldn't have been a problem, and if efflux and porins are taken out of the picture, then we would have had very high rates for the combination of Astronam avibactam as far as Pseudomonas is concerned, just like Klebsiella. So if you look at something like Klebsiella, you don't have a lot of problem with efflux. Porin is described, but again, not a huge problem yet. PBP is not a major problem there. And almost all the enzymes which are clinically relevant for Klebsiella are well inhibited by avibactam, and that is what leads to such high susceptibility rates for the combination of Astronam avibactam as far as Klebsiella is concerned. But Pseudomonas, there is a problem at every step. So let's talk about enzymes and avibactam in the setting of Pseudomonas. So like we said, PER and Web, these are enzymes that are not well inhibited by avibactam. So PER and Web can be problematic. Pseudomonas can have its own oxas, 2, 5, 10, 50. These are oxas which are well described as far as Pseudomonas is concerned. Out of that oxa, especially mutated oxa 10s, can be a problem as far as avibactam is concerned. See, it needs to be an enzyme that is not inhibited by avibactam, and it itself inhibits, or it itself hydrolyzes Astronam. You need to have that type of an enzyme for it to be a problem. Now, you could also have, like I said, JES. So JES can be a problem. Certain variants of JES can be carbapenemases. They can also destroy Astronam, not just carbapenemases, but they can also destroy Astronam. And the problem there is that certain JES variants may not be well inhibited by avibactam. So look at this study from Spain here. 9 Cas-Avi resistant JES producing Pseudomonas. 5 of these were JES 20. Because normally, if you have a purely JES producing Pseudomonas, and if you don't have non-enzymatic mechanisms, it would be expected to be susceptible to ceftazidime avibactam alone. You don't need the Astronam there because JES is a class A enzyme. But like I said, there could be JES variants that are not well inhibited by avibactam. From KPC variants, mutated KPC is not a major problem in our setting. Structural modifications in PDCs or AMCs that impact the ability of avibactam to inhibit this enzyme have also been described. So that's why enzymatic resistance itself can be complex in Pseudomonas. And add to this the fact that Pseudomonas has a significant amount of non-enzymatic resistance. So you could have efflux mutations there. You could have porins which can give you increased MICs for carbapenem. So if you see a report that has increased carbapenem MICs, but cefepime, ceftazidime, piperacillin, tazobactam all are susceptible, then that could suggest a porin mutation there. So there are a number of other problems when it comes to Pseudomonas. So with this background, what does it leave with in terms of options? So one thing could be using Cas-Avi plus Astronam or Astronam avibactam, as we just heard. Like I said, this can work, but provided you don't have any of these problems. You cannot have an enzyme there that is not well inhibited by avibactam, and that's going to go and destroy your Astronam. That's important. And then non-enzymatic mechanisms also have to be ruled out. In India, a lot of our isolates, class B plus non-enzymatic mechanisms, both can be there at the same time, and that is what makes it problematic. If you see global data, then Astronam avibactam doesn't seem to have great numbers as far as carbapenem resistant Pseudomonas is concerned. But just very recently, this was published, and that this showed that they had 42 isolates, and they actually saw synergy in 12 of these isolates. Synergy was done by broth microdilution. So 12 of these isolates, this was just very recently published, probably last week or so in IJMM, and 12 out of these 42 isolates had synergy positive for Pseudomonas. So I think that's a very good number there. 30% of our Pseudomonas, if we can get Astronam avibactam as susceptible, that's a big problem solved, because carbapenem resistant Pseudomonas is really, really difficult to treat. One of the reasons is that if you have to fall back on polymyxin containing regimens, we saw yesterday during the PKPD talk that polymyxins have big problems when it comes to pulmonary infections, when it comes to meeting the PD targets. Also, the partner drug for Pseudomonas is a big problem there, because while you can rely on, let's say, a minocycline or a tigecycline in the setting of Acinetobacter, all those options are gone because of inherent resistance. You can't rely on minocycline, tigecycline, Bactrim, chloramphenicol, nothing. So that's why the partner drug, as far as polymyxins are concerned, remains a big problem, and especially when you have NDM producing isolates which are also resistant to aminoglycosides or fluoroquinolones additionally, then it becomes a big problem. So this, I think, is very good data. In our own hospital also, we have about a 20-25% synergy rates for Pseudomonas. So that is something that has to be pushed, the testing as far as synergy is concerned for carbapenem resistant Pseudomonas. Again, you will 70% of the isolates may not be susceptible, but those 30% which are, it's absolutely worth the testing, because you will have a good safe option for these kind of 30% isolates. So that brings us to certain newer drugs like cefdiericol, and Soman sir just showed us the data. So cefdiericol, if you look at non-susceptibility in cefdiericol, then CR enterobacteria is a big problem. For CR Pseudomonas, the resistance rates are not very high. The beauty of cefdiericol is that it is not affected by class B enzymes, and it is also not affected to a large extent by non-enzymatic mechanisms of resistance. So we just said that in India our main problems are class B enzymes and non-enzymatic mechanisms of resistance. So actually cefdiericol should be a good answer. The data is, I mean, the data for carbapenem resistant Pseudomonas looks quite decent. The problem is again access and availability of cefdiericol. So that is one major issue. And then definitely you have cefepime zidibactam, which will probably there in the next few months, and that looks like a promising drug. Here the beauty of cefepime zidibactam is that zidibactam there is not just a BLI, it additionally has antimicrobial properties. So it is also going to bind to PVP2, and there is complementary binding there. So so cefepime is going to be a potent inhibitor of PVP3, and this will bind to PVP2. So a lot of so there is complementary binding, and zidibactam itself can have antibacterial properties. See, none of the other BLIs that we use currently in clinical practice, except sulbactam, which we'll come to when we talk about Acinetobacter, really have antibacterial properties. Even taniborbactam, which is going to, which is a potent inhibitor of NDM, actually is not a antibiotic enhancer or doesn't have antimicrobial properties on its own. So this by far has the most potent antimicrobial properties. So cefepime taniborbactam again is encouraging because taniborbactam can inhibit NDM, but unfortunately the data really hasn't looked good for cefepime taniborbactam at all. Large part of that has been PVP3 in E. coli and outer membrane proteins in Klebsiella. These are two important reasons why the cefepime taniborbactam data really hasn't looked as good as one would have thought it would have, considering the fact that taniborbactam is an inhibitor of the class B enzymes. Zidibactam itself again is not an inhibitor of class B enzymes, but the beauty of zidibactam is that it itself has antibacterial properties. So look at these two here, ceftazidime avibactam non-susceptible Pseudomonas. So essentially what you're looking at is NDM producers to a large extent, maybe efflux producers as well, and rarely maybe those enzymes that we talked about that avibactam cannot inhibit properly. And ceftriaxone tazobactam. So ceftriaxone tazobactam again is a good drug for non-enzymatic mechanisms of Pseudomonas. So again, if there is an NDM production there, it will be a problem. So if you look at these two numbers, 89% of the Cas-Ave non-susceptible Pseudomonas had good MICs, and 90% of the ceftriaxone tazobactam non-susceptible Pseudomonas had good MICs. It actually it tells you that this is a good drug to look forward to, considering our mechanisms of resistance. Again, class B and efflux are our important mechanisms of resistance. And then this study which shows the efficacy of cefepime zidibactam in the face of efflux mutation. So if you have, even if efflux was raised or highly raised, still the MICs really are not out of the window. So still you can have isolates which have decent MICs, quite a few of them. If you especially see those 188 isolates in which efflux was raised, many of them still would have MICs of up to 4 or 8. So I think these are good numbers to look at. So that's why cefepime zidibactam can be a good drug. So summarizing Pseudomonas, what are our options? Cas-Ave plus Astonam or Astonam avibactam test and use. Here, Astonam, I would say Astonam avibactam MIC would help us more than just whether the synergy is there or not, because especially if the synergy fails, then all that we know is that the MIC is above 6. But still, we want to know the actual MIC. Let's say you don't have any other option. Still, if you have an MIC of around 8, it still might be worthwhile playing around with the pharmacodynamics. It might still be worthwhile using something like an Astonem avibactam, is because we really don't have good drugs at this point of time as options. Then polymyxin plus fosfomycin has often been used as a combination regimen for difficult to treat pseudomonas, and usually that is what we do in our settings, especially if the synergy fails. Now, there are some case reports of Cas-Avi also being used with fosfomycin, or Cas-Avi Astonem with fosfomycin, and there is a little bit of upregulation of penicillin binding proteins when you throw fosfomycin into the picture. But these are extreme situations in which you really have your back against the wall and you are trying to use salvage regimens. And then, like we said, other agents, cefepime, CD-Bactam, and cefderichol could be useful agents to look forward to. So let's look at a case like this. This is a 59-year-old male who was evaluated for pancytopenia, was found to have hairy cell leukemia, was started on cladribine, completed 7 days of therapy, and 3 days post cladribine developed fever and cough. Procalcitonin was 4.8, neutropenic, thrombocytopenic, creatinine 1.3, was started on piperacillin tazobactam empirically for febrile neutropenia, and the cultures were sent. A CT chest was done, and the CT chest shows air bronchograms, typical bacterial looking consolidation. Started becoming hypoxic, saturation was 96% on 3 liters, was shifted to the ICU, was started on meropenem and teicoplanin. Overnight there was respiratory worsening, was intubated, early morning started requiring noradrenaline, and the BAL was done at that point of time, and a BAL biofire was sent. So this BAL biofire is showing Pseudomonas 10 to the power 7, and it is saying that none of the markers of resistance are detected. So which means that IMP, VIM, NDM, which we said are important class B enzymes, are not there. And of course, OXA48, you wouldn't expect it to be there. KPC also very, very rare in our settings, and CTXM also is extraordinarily rare when it comes to Pseudomonas. So the only information really that I get from this kind of an enzymatic test as far as Pseudomonas is concerned is that there is no class B enzyme there. Other than that, you don't get much, because like we said, you could have several other enzymes which could be problems in Pseudomonas. You could have the class A ESBLs like PER and Web. You could have class A carbapenemases like JES, right? You could have some OXAs which could be a problem. You could have PDCs. You could have class C enzymes there which could be a problem. And more importantly, you could have non-enzymatic mechanisms of resistance here. So what do I do with a test like this? Would I continue the meropenem and say that there is no resistance marker detected? Usually I will never use meropenem for Pseudomonas, especially with this type of a report, because a lot of the isolates in our settings turn out to be pan susceptible, 80 to 85%, and the remaining almost always turn out to be carbapenem resistant isolates. We very rarely have this phenotype of ESBL Pseudomonas in our kind of setting. So just using meropenem and saying that only PER and Web would be produced in isolation, that won't be the right thing to do. Then do I say that there are no resistance markers detected, so I can de-escalate to something like a piperacillin tazobactam or cefepime? Would that be the right thing to do? Again, you are worried about AMC when you have used carbapenems, although it was used for a very short duration there. But the other problem is that you haven't detected a lot of the other mechanisms of resistance there. Sick patient, so it probably won't be the right decision to de-escalate without knowing what the other mechanisms of resistance are. And we are stuck at this point of time because there are not too many ways of finding those mechanisms out. But what we can do is stop the teicoplanin. I think that's the only thing you can do from this biofire report. That poor teicoplanin, which was unnecessarily there, now can just rest for a while. So this teicoplanin was stopped, and the lab called saying that there is GNB in the blood, and NORAD requirement was static at that point of time, but it was there. Remember, this was a patient who was doing fairly well about 12 to 18 hours back. So there is a GNB in the blood, and sepsis flow was done, and now it says Pseudomonas aeruginosa, resistance marker detected is JES. So now it tells us one thing, that thank God we didn't de-escalate to piperacillin tazobactam or cefepime. But still, it doesn't really solve the problem of which antimicrobial to use. So in Pseudomonas, if you are given a resistance mechanism, you can rule in resistance. There are many mechanisms of resistance in Pseudomonas which can't be ruled out. So again, with a JES producer there, maybe one thing to do is use Cas-Avi monotherapy. But again, I need to be really confident that the avibactam there is going to inhibit the JES. Can I say that this JES is likely to be an ESBL variant and use meropenem? That again would be extraordinarily brave, because more JES variants are carbapenemeses than ESBLs. And with the data that avibactam may not always inhibit all your JESs, and more importantly, you could again have non-enzymatic mechanisms of resistance there. So you could easily have a JES plus an efflux mutation or an efflux pump there. So that's why just using Cas-Avi also becomes a problem in this type of a patient. Now I'm fairly confident that there is no class B production there, but I still don't know about the other mechanisms of resistance. We talked about this. So you started on poly B and phosphomycin, and that is when the only thing that can really help you is when you get the full culture report. And the full culture report shows ceftazidime avibactam, which is susceptible. So now you know that this is all falling into place. There are no tricks that the Pseudomonas is playing apart from the JES. So you have JES, which is getting inhibited by avibactam, and that's why ceftazidime avibactam can be given. So change from polymyxin, phosphomycin to Cas-Avi over the next 3 days, he clinically improved, completed 14 days of Cas-Avi. So that is why Pseudomonas in our settings can be difficult to deal with. Now let's go to a case of Acinetobacter. So look at this kind of a patient here: piperacillin tazobactam resistant, meropenem resistant, imipenem resistant, amikacin resistant, cefepime resistant, mino is susceptible there, and colistin is intermediate. So again, starting with the questions that every time you look at a report and every time you think of an organism, what are the different resistance mechanisms that are likely to be present? So if you look at Acinetobacter, then there are 5 main carbapenemeses of Acinetobacter, but really overwhelmingly the first 2 are the most important ones. So if you look at NDM and OXA23, a lot of our resistance is actually mediated by NDM and OXA23. And again, the problem is that till Durlobactam is there to inhibit OXA23, we don't have a BLI which can take care of these 2 main carbapenemeses of Acinetobacter. And it's not just the oxas of Acinetobacter, we also have plenty of NDM. So in our study, almost 50% of the isolates were also producing NDMs. So NDM producing Acinetobacter is a big problem, not in isolation, but also with something like OXA23. So OXA23 plus NDM is an important mechanism of carbapenem resistance in our settings. Also add to this the fact that you don't have too many other options. So invariably you will find that the aminoglycosides are resistant, fluoroquinolones are resistant. So one important thing is to make sure that you're testing for both minocycline and tigecycline, because resistance for one or susceptibility for one, really you can't extrapolate this data and try and guess the resistance or susceptibility to the other. So mino resistant may not mean Tg resistant and vice versa. There are different mechanisms of resistance. There is TET-B, TET-X. I won't go into the details of that for the lack of time, but there are different resistance mechanisms, and that's why resistance for one really will not tell you resistance or susceptibility for the other. So important to test. And not just that, like we saw yesterday, we also want the MICs there, because depending on the site of infection, you want to actually also decide how you're going to go about the dose. If both are susceptible, which one are you going to pick out of tigecycline and minocycline? So there are many things there. And in case of tigecycline, you need to look at not susceptible or resistant, but actually the MIC that is there, because you want to look at the MIC, you want to look at the site of infection and so on. So the first question is that in such a situation, when you have a carbapenem resistant Acineto, and we know that it is very likely to have enzymes like NDM or the oxas, especially OXA23, monotherapy or combination therapy. Now we looked at the polymyxin data yesterday, that it is difficult to achieve a 2-log kill with polymyxin monotherapy, and polymyxin nomenclature has now been changed for a reason. So for a few years this was debated, but in the last guidance statement, IDSA has clearly put it up there that the panel favors the use of combination therapy for carbapenem resistant Acinetobacter. Lack of robust clinical data supporting the treatment with monotherapy. High bacterial burdens are expected, and you could develop resistance while on therapy. So what is the role of polymyxins? In most of our isolates, polymyxin would be considered a backbone, but there are problems there. Like we saw yesterday, there are problems with the PKPD of polymyxins. Pulmonary infections, especially a problem. I said that in my ICU, majority of our VAP is actually from a carbapenem resistant Acinetobacter. So there are several problems. So which means that we would favor combination therapy. Now the question is that which combination therapy would you favor? Again, there are 2 fairly large studies which have shown that the combination of polymyxins plus meropenem really don't add much to polymyxin. monotherapy. So both this study, which was published in 2018, and this was published in 2022. So IDA as well as overcome. Both these studies showed that the combination of polymyxin plus meropenem may not be the answer to our carbapenem resistant Acinetobacter. So now we are saying that we want combination therapy to be used, but we are saying that we don't want the combination of polymyxin plus meropenem to be used. So now what do we have as options for carbapenem resistant Acinetobacter infections? So this was a very good study which looked at OXA 23 plus NDM. So when you look at gram negative resistance, we need to think about the problems in terms of the mechanism of resistance in our settings, because if you look at global guidelines, they don't quite address the kind of problems that we have in our settings. For example, if you look at guidance saying that ceftolozane tazobactam can be an option for carbapenem resistant pseudomonas. So this is carbapenem resistant pseudomonas, but not carbapenem is producing pseudomonas, right? So that's why we need to look at our own mechanisms of resistance and try and think about generating data or reading data which will cater to those resistance mechanisms. So we said that NDM plus OXA23 is a problem. In this study, minocycline plus sulbactam actually showed good in vitro efficacy when it came to this particular resistance genotypes, the NDM plus OXA23. And if you look at studies, then in general, colistin, sulbactam, tigecycline, or polymyxin, sulbactam, minocycline. So these have been the kind of regimens used. So you could approach it again in a stepwise manner. First, look at all the MICs, make sure that this is a carbapenem resistant isolate, which unfortunately will be the case more often than not. Then look at polymyxins, try and get accurate polymyxin MICs, look at the site of infection, ask your lab to do minocycline as well as tigecycline susceptibilities. Then again look at the site of infection, look at the mino TGA MICs, decide which out of these you're going to pick, what dose you're going to use. We saw yesterday that as the MICs of minocycline start going above 1 and 2 for sure, there is a lot of merit in using high dose minocyclines. Tigecycline, again, we said yesterday during the PKPD talk that the site of infection is extremely important. Even if I have slightly higher MICs, I'm dealing with something like a biliary tract infection, it's a great drug. Of course, Acinetobacter cholangitis would be an extraordinarily rare situation, but these are the kind of decisions that you need to make based on the site of infection. And then last but not the least, we also said that sulbactam, the dosing needs to be really good, because a lot of our isolates are expected to have high MICs. We don't have great accurate data as far as the MICs are concerned, because we don't do the manual broth microdilutions for sulbactam. But if you look at Asian data, then a lot of the crab isolates, CRAB, it's not CRAP, it's CRAB, a lot of the crab isolates, carbapenem resistant Acinetobacter, these kind of isolates do have high MICs for sulbactam, often MICs ranging from 16, 30 to 64 and so on. And for these type of isolates, again 9 to 12 or a total daily dose of 9 to 12 grams of sulbactam has been recommended. And then sulbactam, durlobactam, again the interesting thing there is that durlobactam can take care of the oxas of Acinetobacter. So we talked about oxas, so oxa 23. So these can be problems in our setting. So all these oxas of Acinetobacter, the oxa carbapenemesis of Acinetobacter, not just 23 but even the others. So you have 23, 24, 51, 58. So all these can be inhibited well by durlobactam. But like I said, NDM still is going to remain a problem in our setting. So in the studies, they have looked at combining sulbactam, durlobactam with imipenem. But that's when you take the oxas out of the picture, and that is when it can be a good regimen. With NDM in there, it is a little bit of a problem, because the in vitro studies don't look that great, of course, when you add NDM to this kind of a picture. So that will still remain our problem, but you can look at it both ways, that 50% of our isolates which are not producing NDMs, we can have a good option for this. So this can be a useful antibiotic, but it's not going to solve all our problems. And again, it takes us back to knowing the resistance mechanisms, and especially knowing the resistance mechanisms in our settings. So I'll summarize by saying that carbapenem resistant Pseudomonas can have many complex resistance mechanisms. Pseudomonas has different enzymes, enzymes like class B's, NDMs, WIM, IMP, PDCs, and AMPCs. Then you could have some other class A enzymes there like PER and WEB. You could have certain rarer oxas there, so those could be problems. Pseudomonas also has a lot of non-enzymatic mechanisms of resistance. So porin mutations, which can raise the MICs of carbapenems. You could have efflux, which can make your synergy of Cas-Av and Astronem fail. So those things are important, and we need to keep those in mind. Astronem avibactam, or the combination of Cas-Av and Astronem, is not as bad as I would say it has been projected in guidelines. And there is definitely a place for us in our clinical settings to look at the synergy of Cas-AV and Astronam. And more importantly, I would also say try and have the exact MIC of Astronam and Avibactam. Because in some cases, you will find that, much to your pleasant surprise, that this is a good option in these type of patients. Otherwise, polymyxin phosphomycin is something that we've been using. Not to say that that's a great option, but we don't have too many options at this point of time. Cefepime, zidibactam, and cefidericol are useful drugs in the space of Pseudomonas. Cefepime, zidibactam, perhaps the one which is which will be here soon, and the one that is quite hopeful as far as the carbapenem resistant Pseudomonas is concerned. And then carbapenem resistant Acinetobacter, we said that consider combination regimens. So our problems are NDM and the Acinetobacter oxas. So consider combination regimens. Get all your testing upfront. Like sir said, we need to have all this information and use and put our best foot forward upfront. So do not extrapolate minocycline MICs from tigecycline and vice versa. The resistance mechanisms are different. We need combinations, but the answer is not polymyxin plus meropenem. So we need to look at the other MICs and the sites of infection and carefully choose our combination drugs. If everything is resistant, including minocycline, tigecycline, then you are probably looking at triple regimens. There you could have polymyxins plus sulbactam plus one out of the two tigecycline and minocycline, depending on MICs or sites of infection. Or there are some in vitro studies which have also looked at a regimen like polymyxin plus meropenem plus sulbactam. Again, high doses of all the antimicrobials that you are using. So combination regimens may have a place, especially if all are resistant. You could even be looking at triple regimens. And though sulbactam, durlobactam is promising, because durlobactam is going to take care of our Acinetobacter oxus, it's not going to solve all our problems, because NDM will still be an important consideration in our setting. I think I'll stop here, and thank you again for the patient listening. Right. So one thing to do would be to look at the MICs of minocycline. Of course, here you are probably not going to be restricted to the combination of polymyxin plus minocycline. Again, sulbactam MICs, like I said, getting those in our settings are a little difficult. You could look at some surrogate markers. I don't think I can even call them surrogate markers, but surrogate clues, like what happens when you use, let's say, a third generation cephalosporin versus a third generation cephalosporin plus sulbactam, and look at the zone diameters and so on. That will give you some clue as to whether the sulbactam is having any effect. But at the end of the day, like I said, one regimen here could be polymyxin plus high dose minocycline plus high dose sulbactam. Tigecycline is something else to look at. If you find an enormous difference between the MICs, that can to a certain extent override the fact that tigecycline is not a great drug for bacteremia. But here again, we are using it as a part of a combination regimen.
Acinetobacter bacteremia is likely to be related to a catheter.
Right.
And
So
that
source
will
control.
have been absolutely removed, no
Absolutely.
question about it.
Yes.
In that situation, maybe tigecycline could help.
Correct. Absolutely.
And of course, it's not monotherapy, obviously. It is just a small part of that whole regimen.
Correct. So if you have a minocycline MIC of 16 versus a TG of 0.5, and if you have taken the line out, we need not really just stick to the fact that tigecycline is not a great drug for bacteremia. Like we discussed yesterday, even for enterococcal endocarditis, when they have been short of options, Dapto plus TG has been used as a combination. So in combination regimens with decent MICs, with other things that are there in our control done, that could be one consideration. So essentially you're trying to analyze between polysulbactam minocycline versus polysulbactam tigecycline, and so on. If both have really very high MICs and you don't have much to offer in terms of source control, then probably you would pick one out of those two with sulbactam with polymyxin, or the other option would be polymyxin sulbactam meropenem kind of regimens, again with high doses.
It's quite complex. Just reading the micro report and looking at MICs and actually looking at the patient and considering each and every one of these facts, like how much can you push the dose, which toxicity is acceptable, and which one is absolutely unacceptable.
Yes.
Like there can be a patient profile where phosphomycin toxicity is unacceptable.
Right.
On the other hand, somebody else may definitely tolerate a good dose of fosfomycin, then it is also being used as a combination therapy. So the totality of the whole thing needs to be seen, you know.
Absolutely.
And what you said about the thing, like if your uh, avibactam aztreonam MIC is closer to 8, still the cas-avi aztreonam, not sorry, aztreonam avibactam thing will work.
Absolutely.
Because,
Especially
you
now
know,
that we are doing better with the PD.
Correct, because even in the licensing studies,
Yes.
up to 8
Correct.
were actually, you know, you had a
Yes.
good probability
Yes.
of joint
Yes.
target attainment.
Especially if they have slightly lower GFRs than normal, this
Yeah.
could actually be a great situation for
Correct,
Astronav.
correct. Up to 8 can
Yes.
also be 8 will technically be reported as resistant, but still one can
Absolutely.
get some juice out
Yes,
of it.
yes, that's why. So that's why for by carbapenem resistant Pseudomonas, I would always insist on the actual MICs. For all of our organisms, we would. So actual MICs are much better than synergies. Before that, when we used to do the synergy alone, often, not often, but in some patients in whom we really didn't have too many other options, we used to also test it by different concentrations so that we are not just restricted to knowing that the MIC is less than 6. You also want to know whether it is less than 6, between 6 and 15. All those combinations can be tried. What would be your choice of antibiotic in a lung infected with the Caritas? Will it be polymyxin plus sulbactam or sulbactam minocycline? Yeah, sulbactam minocycline. See, if it depends on how good the minocycline MICs are. There again, the pulmonary concentration of minocycline is not extraordinarily high. It's not like a linezolid, but it also depends on what the minocycline MICs are. We know that polymyxin is not a great drug for the lungs, but when we are looking at polymyxin studies and lung mice models, they are essentially monotherapy models. So here the options are either using something like a minocycline plus sulbactam as combination regimen, or if you have a good MIC of minocycline, using poly plus minocycline as a combination regimen. Monotherapy. So that brings us to the question that can we use monotherapy with minocycline? If you look at the literature and if you look at monotherapy with minocycline, the success rates are not higher than about 60 to 70%, which are not very high success rates. So usually in my practice, I try and avoid in most situations minocycline monotherapy for carbapenem resistant Acinetobacter.
In that situation, minocycline should also receive a no labeling for susceptibility. It will have to be considered as only SDD intermediate. Correct. And resistant.
Absolutely. And these are the kind of situations in which you would look at what we discussed yesterday. Is there any merit in adding inhalational therapy on top of this? Because there you can go higher with the doses, and these are all the things that we do to sort of supplement our backbone regimen. No, if you have a minocycline which is susceptible, usually you would go for something like a polymyxin plus a minocycline combination. You would usually not use minocycline monotherapy. Polymyxin monotherapy is out of question, but even minocycline monotherapy is not something that you would favor. If minocycline is also resistant and you have bacteremia, then you are often looking at triple drug regimens like we described.
What might be since you are not having a broth microdilution for sulbactam,
Right.
Is there any merit in looking at cefoperazone sulbactam and seeing whether it is at least intermediate?
Yes.
Because if
absolutely.
it is so, then we can conclude perhaps that because you have a carbapenemase,
Yes.
right? So you definitely don't think that the cefoperazone part of it is working at all.
Correct.
So whatever intermediate zone or whatever level
Absolutely.
might be contributed only
Right.
by sulbactam.
Right. Absolutely.
In which case, if you jack up the sulbactam,
It can be.
It can be
Yes.
one way of
Definitely.
a poor
that's
man's way
something
of
that
looking at sulbactam
Yes.
susceptibility.
Yes. Like I said, this is definitely something that you do look at the differences in zone diameters between third generation cephalosporins and third generation plus sulbactam. Because of the fact that they have OXA 23 and NTM, we are not expecting the third generation cephalosporin to add anything at all to that combination. So that's why, and I'm leaving ceftriaxone sulbactam out of this combination. So if you look at the other third generations versus third generation sulbactam combination, that can be, like I said, a surrogate way of looking at it. Right. Right.
Correct.
Correct.
That
But
is
but see,
only
but
the-
if it is frankly resistant, then it
Ah.
becomes a problem.
Yeah.
So if you get it as intermediate, there is no doubt about it.
Yeah,
But
that
if you get
means
it
that
as
it
frankly
will work.
resistant, the question is how much is it adding? There, slightly zone diameters can help you, third generation versus third generation sulbactam.
Correct. And no talk of Acinetobacter can be complete without ceftriaxone, sulbactam, EDTA. So no, I'm surprised nobody has asked this question. No,
No, I think it's more popular
for a good reason.
for a good reason.
So, so you talked about polymyxin plus IV phosphomycin for difficult to treat pseudomonas. So, can you tell us more about the dosing and monitoring parameters when we're using IV phosphomycin and also the duration of treatment?
So, dosing there is not very well standardized because remember you are using a drug that is expected to have high MICs as far as Pseudomonas is concerned. So, this situation is very different from when you are using phosphomycin with polymyxin, let's say for an E. coli, wherein you are expected to have good MICs. There you are basically using it as a part of a combination regimen. Higher doses are recommended. We saw yesterday that with augmented clearances, especially higher and with high MICs, higher doses are recommended. But those were again charts for monotherapy. So higher doses are recommended. The question with polymyxins, phosphomycin often is that how much can you give? So usually 12 to 18 grams per day is recommended, but your patient profile dictates the dosing to a large extent.
Sir, you told Darlobactam will inhibit the oxas produced by Acinetobacter. Then any possibility of using triple combinations like polymyxin, sulbactam, and Darlobactam?
Correct. So that can be one thing to be thought about. But see, with NDM in the picture, what will often happen is that although Darlobactam is knocking out the oxas, essentially we'll be left with a situation like an NDM producing Acinetobacter, and we are using a polysulbactam combination regimen. So that is what we will be left with. See, now Oxa 23 being taken out of the picture is also an interesting scenario from a sulbactam point of view. So that is also something to be considered. So definitely we have to, so a lot of the global data that has been published so far looks at adding an imipenem to sulbactam darlobactam combination. So polymyxin plus sulbactam darlobactam, and maybe in that situation, do we need another drug like minocycline are things that we will have to look at, when the drug comes here. But you are right. If you knock out Oxa 23, there is going to be some benefit, I would assume, even from the sulbactam point of view. But again, it's not going to solve our problem entirely, because if you knock that out, we'll essentially be left with Acineto, NDM, and polysulbactam as antibacterials.
In that case, can sir is telling like you will remove the polymyxin from that combination and add minocycline or tigecycline, like.
So no, I wouldn't do that unless I really know that the minocycline MICs are good. So that probably wouldn't still be there, because still you have an NDM producer there, which means that it is an Acinetto which is NDM producing. So you can sort of extrapolate that situation to a pure NDM producer in our setting. So what would we have done had we had an Acinetto which is only producing NDM, right? The logic would be the same. Would we have gone with minocycline monotherapy? The answer is no. Would we have looked at minocycline plus sulbactam if the minocycline MICs are good? Then depending again on the site of infection. But usually for most of my carbapenem resistant Acinettos, we still tend to use the polymyxins as backbone. So what I am expecting is that when sulbactam darlobactam comes here, we would probably be using it as a better combination regimen with polymyxins than what we have right now. So let's say a polymino plus a sulbactam darlobactam for especially resistant isolates.
No, but Parikshit, the NDM itself is going to destroy the Darlobactam.
Right, exactly.
So how will it help?
No, so exactly. So that's what I'm saying. So poly plus
you're
sulbactam.
just thinking of a polymyxin plus sulbactam, or otherwise
Right.
minocycline
Exactly.
plus sulbactam.
Right. So that's why I said
That's
only
not going to
polymyxin
work.
and sulbactam is going to remain.
Correct.
So only polymyxin and sulbactam is going to remain. So that's why I don't expect poly plus sulbactam darlobactam to be a two-drug combination regimen. You would still have another third drug there.
Correct. So actually, we will be using a very expensive imported or newly introduced drug,
Yes.
and have it destroyed by the NDM. So it really makes no sense at all. So sacrificial lamb, I would say.
Absolutely. So you're right. That polysulbactam is what is going to remain, and Acinetto is what is going to remain there. So.
If I request a quick snap of the faculties, please. Because Dr. Parishit and Dr. Pravin will be leaving right now. Any questions to the both of them? They are leaving right now. Okay. So I'll have a quick snap. You have here only. Arun sir. You have it. Snap photo.
The next section, I invite Dr. Aravind R. to deliver his talk on severe acute respiratory infections in ICU. Dr. Aravind R. is a distinguished physician and infectious disease specialist at Government Medical College, Trivandrum. His clinical expertise and sincere commitment to patient care have earned him the respect of both colleagues and the community. He has played an important role in Kerala fight against two major public health challenges of our time, the COVID-19 pandemic and the Nipah virus outbreak. Sir, please.
Good morning, everyone. I'd also like to thank Jacob and team for the opportunity. So next 20 minutes or so, I will take you through the problems that we deal with regard to SARI in the ICU, that is severe acute respiratory tract infections. So this patient, came to a tertiary care center ER in North Kerala around 2 years back. A 47-year-old gentleman on treatment for psoriasis, present with a history of fever, myalgia, headache, 5 days duration, cough of 2 days duration, and dyspnea of 1 day duration. A provisional diagnosis of SARI viral bronchopneumonia was made. In view of ARDS, he was intubated and mechanically ventilated. So, what is the ideal strategy? So, will we start oseltamivir immediately and then send for SARS-CoV-2 and influenza PCR, or will we start oseltamivir immediately and send for multiplex PCR panel as we are used to doing in majority of the corporate centers, or start ceftriaxone doxy plus oseltamivir and send for respiratory panel and the tropical fever PCR panel, because we have a problem with scrub also in the state. So I will come to this at the end of the session. Okay. So when we are supposed to approach any patient with acute febrile illness, the aim is actually from the history and examination to have some sort of a syndromic diagnosis in place. So obviously, multiple studies have shown that in acute febrile illness, the most common etiology, the syndrome is likely to be influenza-like illness. And if ILI requires hospitalization, we'll refer to it as severe acute respiratory tract infection. And if you are not able to, from the history alone, if you are not able to pinpoint to an organ system, like the patient is present fever, headache, myalgia, fatigability, like in case of dengue, chikungunya, Zika, etc., then we will label it as tropical fever syndrome, especially in Kottayam, where we have a huge amount of leptospirosis, etc. All these things will be bracketed under the tropical fever syndrome. And third is actually the organ specific syndrome. That is, from the history, you will get a clue towards the organ system that is involved, like genitourinary system, CNS, and all those stuff. So I will be focusing on the first part, that is basically ILA as well as SARI, and these two are the surveillance definitions which have been proposed by WHO, because influenza infection causes a clinical syndrome which is not easily distinguished from other respiratory tract infections. So the definitions of ILA and SARI are not necessarily intended to capture all cases. It is just to describe trends over time, so that the states and country can compare with each other with regard to the prevalence of ILA as well as SARI. The case definition of ILA is an acute respiratory tract infection with measured temperature, fever more than 38 degrees Celsius with cough, and onset within the last 10 days. If along with these three, the patient requires hospitalization, that is dyspnea as well, it is termed as severe acute respiratory tract infection. So in our context, the DDs that we need to consider when we are, like a clinical diagnosis of ILA or SARI is made is a COVID-19, influenza, RSV is a problem. We all know that adenovirus infection. Since now we are using more and more molecular tools after the advent of the we after COVID. Now we had access to a lot of molecular tools, and we get a lot of adenoviral. Now we get to diagnose a lot of adenoviral pneumonia as well, especially in immunocompromised children, etc. Especially those in RCC and all. Adenoviral infections can lead to severe pneumonia as well, severe SARI as well, and even some children might require treatment with cidofovir. And with regard to influenza, so we have to subtype the influenza to see whether it is influenza A, B, and A again H1N1 and H3N2. In our setting, the subtyping is very, very important, because suppose it is influenza A and we are not able to subtype whether it is H1N1 or H3N2, we need to always think about avian influenza as well, because all the districts in Kerala has reported avian influenza in ducks and poultry in almost all the bird species and certain mammalian species last year itself. And Alleppey and Kottayam are two districts where at any point of time a spillover from the poultry or duck to the humans can occur. So if you are not able to subtype this influenza A into H1N1 or H3N2, think about the possibility of avian influenza as well. Then coming to other possibilities, infections like the metapneumovirus, the Boca virus, etc. also can lead to SARI in children as well as immunocompromised patients. And we know that mycoplasma also is a huge problem in the state. So coming to the influenza per se, so like usually we used to use the quadrivalent vaccine, but after 2020 March, we don't have this Yamagata in circulation. So now the trivalent vaccines are as good as the quadrivalent vaccines. Basically, influenza B we are referring to as the Victoria strain. And regarding the zoonotic or the avian influenza, H5N1 and H9N2 have been reported in the state over the last 5 years or so. H5N5 and H7N9 has not been reported. Now coming to the optimizing the pre-test probability, that's basically you know that a patient is having ILA or SARI, and what all tests to be ordered to come to a diagnosis depends on the geographical location, then the seasonal trends, occupational exposure, travel history, animal and vector exposure, food and water exposure, contact history, host related factors, etc. So based on this, you need to take a call on what test to order, etc. Because sometimes, for example, like the avian influenza season is going on, and a person is developing, a person involved in culling is developing severe pneumonia and all. So based on these factors, you need to talk to the microbiologist to ask for specific testing to rule out avian influenza as well. Now coming to the outcome determinants in cases of SARI, it depends on the virulence of the virus, the host factors, the inoculum load, and in pregnancy, it's a huge issue, because I think 2 days back our the sample registration survey report came out, and Kerala, the maternal mortality is the lowest in the country, is around 24. But in 2021, usually we have around 130 mothers dying out of 1 lakh pregnancies. But in 2021, we had around 230 maternal deaths due to COVID alone. Okay. So, and the risk factors were, at that time we are not vaccinating the pregnant ladies. Okay. So, vaccination status, hybrid immunity, as well as the trimester of pregnancy is very, very important. In third trimester of pregnancy, the COVID-19, etc., can be a killer. Now, WHO has very good resources like it has the GISRS, the reporting framework, where you can track the viruses circulating in the WHO regions as well as to the country level. And recently they have introduced this assessment as well, that is the pandemic influenza severity assessment, or the PISA assessment. So based on factors like the transmissibility of influenza, the morbidity and mortality profile, and its impact on the healthcare delivering capacity, and based on that, they have given a color coding, etc. So this is actually the PISA score for New Zealand. So why I'm taking the PISA score for New Zealand, because in the Southeast Asia region, only Bangladesh is reporting data. If you search India, there is nothing available in the JSRS network as far as the PISA score is concerned. Okay. Now coming to the approach to the patients with ILI, all of us are familiar with this ABC guidelines released by Government of India, by which we are supposed to categorize the patients into A, B1, B2 and C category. A means actually mild symptoms, B2 means the severity is a bit more, B1 is a severity is a bit more, B2 is actually mild symptoms in patients who are immunocompromised like pregnant ladies, elderly, etc. C means those who are having complications, dyspnea, hemoptysis, those who require admission. So the national guidelines stipulate that from B1 onwards you can start oseltamivir with or without testing, and C requires hospitalization. And the antivirals which are available, which are active against influenza, are the neuraminidase inhibitors, of which I think only oseltamivir is as of now available in India. And zanamivir and landamivir are supposed to be taken as the meter dose inhalers. And zanamivir, you need to have a BD dose, and landamivir is not US FDA approved, but it is available in Japan. The difference between the two is that landamivir has the duration action is a bit more than zanamivir, so it can be given as an OD dosage. The peramivir is the IV option, which is also not available. So in severe influenza and all, if you have access to peramivir, it can be tried instead of oseltamivir. And baloxavir is approved by US FDA, but we don't have robust data in severe influenza. We don't have data in immunocompromised patients as well for baloxavir. So as of now, our treatment of ILI, if you're suspecting influenza, depends solely on oseltamivir. Now coming to the complications of influenza that we should be knowing, the most important thing is secondary pneumonia, because the mucosal integrity etc. will be sort of altered by the influenza virus. So there is always a chance of secondary pneumonia by pneumococcus, staph aureus, etc. But one thing that we should know is that antibiotics used upfront is not going to prevent a secondary bacterial pneumonia from occurring in any infections. Okay. And we need to look into other complications like the possibility of rhabdomyolysis, encephalitis, myocarditis, Ray's syndrome in children, and influenza associated pulmonary aspergillosis as well. Suppose a patient is developing a secondary pneumonia, and if it is not responding to usual antibiotics, please do think about the possibility of influenza associated pulmonary aspergillosis as well. Now you must be remembering that in 2023, so the state government came out with a guideline regarding, there's a technical guidelines with regard to management of influenza associated encephalitis in the pediatric population. So why did the state come out with a guideline? So just like what happened in I think Gujarat with Chandipura virus infection, we also had the same problem. So kids developing a slight respiratory tract infection, and then within say 24 to 48 hours presenting in a comatose stage. So basically it was not a SARI followed by encephalitis, it was just an antigenic trigger in the form of a very mild influenza, and the patients were presenting in a comatose state with cerebral edema as well. And the only option, so in 2019, our pediatric center SAT published a case series on influenza associated encephalopathy in kids, where the mortality rate was 18%. Whereas in 2023, the mortality rate used to be around say 35%, and then the state had an emergency meeting, and the only way to save these kids was to actually pulse the patients immediately with mideprednisolone, because it was not actually due to the severity of influenza per se. It was like sort of a cytokine storm which is occurring in the brain, because the severity of influenza per se was very mild, just having a mild fever, rhinitis, etc. Okay, it was actually in the post-COVID period as well, and state had to come out with a guideline to say to pulse mideprednisolone in a child with encephalitis. And usually they used to come in the evening, and suppose they are waiting for the senior consultant to come, that's by morning they used to be sort of brain dead. So the only option was to pulse them with mideprednisolone. So this complication, especially in the pediatric population, we need to be aware of. And all the pediatricians are aware of this complication. But suppose the kid happens to be 13 years old, then the problem arises, because it will come to the adult side. And majority of the physicians are not really aware of the dramatic presentation of influenza associated encephalopathy. And coming to H5N1, that is a spillover of H5N1 from the avian host to humans. So there are multiple sporadic case reports in India. The first one is actually a traveler from India was diagnosed to have avian influenza from Australia. So this person had actually traveled from Calcutta to Australia, and they picked up as part of their routine surveillance picked up, avian influenza by sequencing, by deep sequencing. Interesting aspect was that this kid never gave the history of contact with any poultry or anything while the kid was in India. So the assumption made was that is there a community transmission going on in India? Sort of, doubts were raised by that article. And also Andhra Pradesh also did diagnose a sporadic case of H5N1 in humans. Now coming to the next infection which can present as SARI, a 91-year-old fever trial cough. You can see that the COVID. COVID is still a major problem in immunocompromised CKD, CLD patients as well as the elderly population. And our major issue is, the elderly population in the state is around 45 lakh and life expectancy is also around 77. That means that there is a large chunk of our population who are still susceptible to development of severe complication due to SARS-CoV-2 infection. And this is our data from 2021. You can see as the age goes up, the case fatality rate due to COVID-19 is also going up. And that is probably the reason, if you have access to, say, annual booster dose, we should be giving to the elderly population, to the CKD patients, post-transplant patient, etc. Because last year also in our state around 60 people died due to SARS-CoV-2 pneumonia, and majority of the deaths occurred in the CKD patients, the post-transplant as well as the elderly above 80 years of age. And the problem with the standard ABC guidelines is that, if a patient is coming to our OPD, we cannot differentiate between influenza and, say, RSV or COVID just based on the symptoms alone, because this influenza as well as SARS-CoV-2 will be having the same symptoms. So in around 3 years back, we fused both the guidelines together, because we had an ABC guidelines for COVID also, because we piggybacked on the influenza guidelines and had made an ABC guidelines for COVID also. And then the state released the combined ABC guidelines for influenza as well as COVID, so that a person in the OPD can make the right decisions. So basically the symptoms are the same. At that time we had access to the rapid antigen test. Influenza diagnosis based only on the PCR, whereas this RAT was available in all the PHCs. So basically for all the A, B1, B2, you test for COVID, and then if it is negative, start oseltamivir like that. But unfortunately now we don't have access to the antigen based test. So basically it is from B1 onwards you start oseltamivir, and if it is C, that is SARI, admit the patient and do test for both influenza as well as COVID. Now coming to the next problem, I think from 2021 onwards, we also started realizing that RSV is a problem in adults as well. Previously, the conventional wisdom is that RSV will lead to a very, very mild infection in adults, and it usually leads to problems, bronchiolitis, etc. only in children. So once we had access to this molecular diagnosis and all, we started realizing there are a lot of adult patients, post-transplant patients, immunosuppressors are also developing severe pneumonia due to respiratory syncytial virus, just like this patient post CABG who presented SARI and ended up in a ventilator, and the PCR was positive for RSV. And by that time, we had data from US showing that annually around 60,000 to 1.2 lakh adults are hospitalized due to RSV, and contributes to around 6,000 to 10,000 deaths every year. So adults can die due to RSV. And interestingly, a MATISSE trial was also released in around 2022-2023, which was the first trial where a vaccine was given to the mother in the third trimester of pregnancy, after 28 weeks, to protect the infants. Because we know that during COVID, because of physical this non-pharmacological interventions, the mothers never had the opportunity to get natural infection against RSV, so that the kids were deprived of the antibody which were transferred from the mothers. Okay, and so the neonates became susceptible to the RSV, etc. So that is why they designed the trial in such a way that the mothers are vaccinated so that the neonates will get the transferred antibodies. It was found to be effective, and now you are having an RSV vaccine licensed in US for people above 75 years of age, and those with comorbidities, it is licensed above 60 years of age. In UK, also the RSV vaccine is approved for use in elderly as well as those who are having other comorbidities. RSV does not have a definite treatment as such, but we repurpose drugs like ribavirin, use remdesivir, especially in patients post-transplant with severe RSV pneumonia. This is with regard to RSV vaccine that we already covered. Now coming to the human metapneumovirus infection, you might be remembering around 2 years back there was a huge cry regarding the human metapneumovirus infections, cluster occurring in China, and will it be the next COVID, sort of things like that. Metapneumovirus was always here, but it is a problem in patients who are immunocompromised, like those who are after post-transplant patients, etc. You can see that in post-hematopoietic stem cell transplant, 60% of the metapneumovirus infections, usually it is an upper respiratory tract infection in adults, this can become lower respiratory tract infection and can lead to mortality in 20%. And the most important aspect is post-lung transplant. If someone is picking up this metapneumovirus infection early post-transplant, in around 33% of them can have chronic lung allograft dysfunction at 1 year of age. So this metapneumovirus also is a very mild infection in the usually in the adults, but in the post-transplant population it is a problem. But we don't have a directed or targeted anti-metapneumovirus drug or vaccine as such. And regarding this Boca virus infection, so when this metapneumovirus infection was becoming a huge news in the media, and IAV published an article. IAV is Institute of Advanced Virology in Trivandrum, published an article saying that around 15% of the SARI in hospitalized children are due to Boca virus in Kerala. So this article also came out, but fortunately the media were behind metapneumovirus, so they never paid attention to this article. Otherwise, it would have made headlines like a new virus has reached Kerala, like the Boca virus in Kerala. Now coming to how we can prevent all these things, and have to rely a lot on the vaccination, especially influenza vaccination, and these are the sage recommendations. The children, healthcare workers, the older adults, pregnant women, all patients with these comorbidities, etc., are supposed to take this annual influenza vaccine. And we are a country in the tropical and subtropical area, so we are supposed to take the vaccine prior to the start of the primary period of increased influenza activity. That is, prior to the monsoon, we are supposed to take the vaccines, and all these things you are well aware of. Every year the vaccine combination will change. The only major difference is that this year onwards, from last year onwards, we need to take only the trivalent vaccine, because the Yamagata strain is not in circulation after 2020. So we have access to egg-based vaccine as well as the cell culture based vaccines. And India comes under the tropical Asia zone, and usually we are supposed to take the vaccine by April. This WHO timelines showing the influenza zones, and we are supposed to take the southern hemisphere vaccine by April. Now coming to another case scenario, a 13-year-old girl with mucositis and oral ulcers. She gives a history of severe acute respiratory infection 1 week back. So what is the diagnosis here? So MIRM is a mycoplasma induced rash and mucositis. Okay, so this is an immunological immune complex deposition in the mucosa, okay, which is triggered by this mycoplasma pneumonia. So now it is said that it is not specific to mycoplasma alone. So it is better to say RIME. That is, RIME is recurrent infection associated mucocutaneous eruptions. Okay, there is a criteria known as Canavan's criteria to diagnose this mycoplasma induced rash with mucositis, because mycoplasma does have other cutaneous manifestations like erythema multiforme, and when multiple mucosa are involved, now you might think that is Stevens-Johnson syndrome as well. So in order to differentiate this mycoplasma induced rash with mucositis from Stevens-Johnson syndrome and erythema multiforme, this Canavan's criteria is used. Canavan's criteria just the criteria are: one is there should be evidence of mycoplasma infection. The second is that the skin involvement should be less than 10%. Usually in Stevens-Johnson, etc., it will be more than 10%. More than 2 mucosal sites should be involved. That is, either the ocular mucosa, the oral mucosa, or the genital mucosa should be involved. And we know that this is the data from the state from 2024 October onwards. We had a peaking of mycoplasma in the state. And this one publication from the top part from Amrita showing that around 30% of the mycoplasma isolated infections were resistant to macrolide. The actual data from China shows that the resistance is to a tune of around 90%. US it is around 5%. In Kerala, from a limited number of samples, the resistance was around 30%. And so there is an algorithm like you start with macrolides, and 3 days, if there is no response, you switch over to doxycycline, and after 7 days, still there is no response. Think about a refractory mycoplasma infection and start steroids, and after 72 hours, still there is no response. You have to take it as steroid refractory mycoplasma, especially if the LDH levels are pretty high, and go for IVIG or a higher dose of steroids like that. Now coming to another usual situation, because since oseltamivir is usually the easiest and cheapest available drug in our pharmacy, we tend to misuse oseltamivir for everything. So this is a 48-year-old lady with bronchial asthma exacerbation following a SARI, and this is our multiplex PCR panel. Human para-influenza was positive. So ideally, we should be stopping everything like ceftriaxone, azithromycin, oseltamivir. But what happens is that as part of stewardship, ceftriaxone, azithromycin will be stopped. But since the influenza part is there, even for para-influenza, we are likely to continue this oseltamivir. Oseltamivir has no action against para-influenza because para-influenza is a okay. Influenza is orthomixes. Para-influenza is the para part of it, and these are this oseltamivir is a competitive inhibitor of neuroimidase. And even though para-influenza also has this hemagglutinin as well as a neuroimidase spike, because of this conformational problem, our oseltamivir won't be able to dock with that. So there is no point in continuing oseltamivir for para-influenza infections. So the right answer here is stop everything. Okay. Now coming to the first question. So here the two options is, one is to go for the syndromic approach, that is use your film array or the targeted IAV panels that we use, or go for target panels. Do you have the pretest probability here? So do you want to rule out influenza first, then go for COVID, then rule out RSV, etc.? Anyone knows the answer in this case? I think presented in multiple other CMEs as well. The clue is actually it's not a case from Trivandrum. It's a case from a private hospital in Calicut, 2023. This is the index case of Nipah in 2023. So that's the real problem. Okay, even Nipah can present with SARI, and the issue here is that the patient was diagnosed as a viral bronchopneumonia and was intubated and mechanically ventilated. So usually in Nipah, natural history of symptoms is like, for the first 4 to 5 days, will be just like dengue, fever, headache, myalgia. Day 5, some patients will develop the respiratory symptoms, and by the end of the 5th day, some patients might develop seizure altered sensory. That is just like a tropical fever syndrome to begin with. Then there is a pulmonary involvement, and then there is an encephalitis. Here, before we could pick up this encephalitis part, the patient had been intubated and ventilated. So there was no, and patient was sedated as well. So whether the patient developed encephalitis later, no one knows. So basically, it was like a patient had come with a viral bronchopneumonia ARDS. And since it was a pneumonia ARDS presentation, a bit of a spread also occurred, and 5 other patients also got infected with Nipah virus. So this is the ground reality. Okay, despite using the syndromic panels or targeted panels, we are not going to pick up any the virus or the pathogen in cases like this. That is the importance of knowing the epidemiology as well. So if you are in a Nipah endemic area like say Calicut or Malappuram, Palgad, especially all the western belt area, any patient who is presenting with a bronchopneumonia followed by an encephalitis sort of presentation, it is always prudent to rule out Nipah, and more important than that, we should always be taking the standard and the transmission based precautions, because the staff nurse who received the patient in the ER later developed the infection. Since he was in our contact list, he had been given prophylactic remdesivir, and he developed only a mild infection. But unfortunately, after 3 months, he had a relapsing encephalitis, which was proven through brain biopsy, and now he's sort of in a vegetative state now after 2 years or so. Okay, and he was the first person to be administered the monoclonal antibody as well. So basically, whether to select the syndromic or targeted panels in SARI diagnosis depends on the pretest probability which can be augmented by giving a clear assessment of the epidemiological factors, the clinical features, the anthropological factors, the immune status of the host susceptibility factors, as well as the test characteristics. And I will end with this. So it was recently published in NEGM, the first human case of H5N1, there's a human infection with the highly pathogenic avian influenza H5N5 virus. So this patient was on treatment for Waldenstrom's macroglobulinemia. It is an old lady, and she had contact with sick ducks in her background. And then she developed this severe pneumonia. The interesting aspect is that despite multiple nasopharyngeal swabs, all the PCRs were negative. They went in for a bronchoalveolar lavage, and then that turned out to be positive for H5N1. So take home message here is that in avian influenza, usually the alpha 2,3 sialic acid receptors are actually present in the alveoli. It's a bit deep. Usually the influenza will bind to alpha 2, which is more expressed in the nasal mucosa. So your NP swab or oropharyngeal swab is likely to pick up influenza, SARS-CoV-2, etc. But in case of avian influenza, if you're strongly suspecting avian influenza, like someone who is having contact with a dead poultry or ducks, etc., and is presenting with a severe pneumonia, and if your the nasopharyngeal swab and oropharyngeal swabs are negative, think about going for a deep sampling, because there is a differential expression of this alpha 2,3 sialic acid receptors in the lower like alveoli, etc., compared to the nasal mucosa. So thank you very much for the opportunity. Okay.
Any questions?
Nice presentation.
Thank you, sir.
I was just thinking about the Nipah. It comes after a certain period of time. So, like suppose if we try to understand the epidemiology, is it that some population of bats which increases, and that really helps in case of increasing in number of these cases, or what is the reason of coming certain period of time and then it goes waning out? So, is there any epidemiological circle could be really delineated out of it?
Sir, actually the ICMR is tracking the antibody levels in the bats at 3 time points. It has been published. It is in February, then May, as well as September. So this is actually the breeding periods of the bat, and this during this breeding season that the maximal secretion of this virus occurs in the genital secretion, etc. The maximum presence of virus will be there. So they have demonstrated that actually from February onwards there is an increase in the presence of these antibodies in the bat, and the maximum is in September. It's around 40% of the bat in the roost in these areas will be having these antibodies, as well as the virus also has been detected in their secretions. And if you're looking at the last 5 years, when the spillover occurred in Kerala, the maximum number of cases has been reported in the September period, which actually parallels the activity in the bats. The bats are not going to get infected, but when their innate immune response goes down, there is increased presence of this virus in the genital secretions. And we are talking about to tunes of crores of bats in this area, like Malappuram, Wayanad, Palkat, etc. A lot of people are living virtually under the bat roost. So we have not demonstrated how the spillover is occurring, because they are never isolated. Like what happened in Bangladesh, they were able to demonstrate that probably date palm consumption is the risk factor. That is how the virus is spilling over from the bats to humans. But in Kerala, whether it is a direct spillover or indirect spillover, till now we don't have any evidence to say that it is an indirect spillover. It's likely to be a direct spillover in contact with the bat secretions as well. For example, last year's one lady, just above her house, the bat roost contained around 15,000 bats, and the droppings were actually falling onto the kitchen, and the area where they were actually laying these clothes to be, like after washing, etc., the droppings were directly falling. So is it contributing to the increased transmission? Really, we don't know. But still, if you're looking at probability, you're having crores of bats and maybe lakhs of people living in this area, and every year we are having, say, 2 to 3 episodes of spillover. So how to prevent that, it is really a very, very tricky affair, sir.
At the same time, if you can look into the population in that area, hyperendemic area, is there any antibody which is being persisting? Like suppose I would say that a lot of people have got asymptomatic, one or two are having symptomatic. Means whole epidemiology we are not still understanding, and suddenly it happens, and suddenly some people die, and we become scared, and suddenly it also went. So we need to understand this Nipah in a bit way because this is very important in that.
So in 2019, so out of the contact tracing, there were around 210 high risk contacts and who did not develop the disease. And ICMR actually assessed the Nipah IgG levels in them, and 1% were found to be IgG positive among the high risk contacts who didn't develop the disease. 1%, that is around 3 people, were found to be have probable subclinical infection, but that has not been done at the ground level, means under the bat rules, etc., because of certain ethical concerns, stigma issues, and all. Because if you find that some people are having antibody, how the others will react, etc., we don't know. So we did not get ethical approval as of now. But among the high risk contacts, 1% had subclinical infection.
Is there any data about the resistance of oseltamivir? We have been using it for quite some time. It's high time it should have resistance.
Actually, from the ICMR data, it is negligible. Oseltamivir resistance in India is negligible, but we need to believe ICMR in that. That's that is up to you whether to believe or not.
No, but what's your take on the controversial publication BMJ, where oseltamivir was found to have not changed, not much of a hospitalization, not much of a severe pneumonia, etc.
The recommendation is actually 2C, to use oseltamivir. But if you are using oseltamivir, the usual thing in the GP practice is, someone is coming with ILI, they will start with augmentin, and day 4 or 5 the patient is not improving, then they will start oseltamivir, and by say 7 or 8 will develop a secondary infection, then they will switch over to some other antibiotic. This is not the way in which we should be using oseltamivir. If you want to use oseltamivir, it has to be in the first 48 hours for B1, B2. Otherwise, not use it. But this cycle is going on. This augmentin, oseltamivir, and then something else.
So is oseltamivir also under the you won't get it without a prescription right now in Kerala?
Antibiotics you won't get it without prescription. Yeah. Oseltamivir also you won't get it without prescription. Actually, sir, the VRDL lab means the isolates are actually ICMR has been tracking. Exactly, but the testing is done by them, sir. So what comes out, we don't know. Prior to 2009, among the circulating influenza viruses, influenza A, the oseltamivir resistance was there. Actually, when this pandemic strain came in, the oseltamivir resistance came down, and I think the last publication it was around 0.3%, something like that.
Sir, other than the corona and influenza virus, what is your experience with other viruses causing ARDS?
RSV. That's RSV is a problem. If you have, because ICMR in 2022 as part of this VRDL lab network, they include RSV as well. Just they are testing for influenza, COVID as well as RSV. And RSV means in patients like immunocompromised patients, those on chemotherapy, those who receiving rituximab, elderly, etc. RSV is a problem. And we had means certain situations we had to use even means we had to repurpose remdesivir as well for treating RSV infection. Sometimes we have to give this IV rituximab thing, IVIG, etc. had to be given. Adenovirus. We had a huge outbreak of adenovirus among this RCC pediatric onco department, and responded only to pseudofovir. And actually, the start was one bystander had adenoviral conjunctivitis. For the immunocompetent, this conjunctivitis, it might remain as a conjunctivitis. But those who are immunocompromised, it will end up as a severe adenovirus pneumonia, and only pseudofovir, with pseudofovir we were able to save the kids. All these things are this thing for remdesivir, etc. Other than COVID, everything else is off label. Pseudofovir, the problem is it's an expensive drug, but we had to use that because the children it was not coming down with. We start with ribavirin, did not work. Tried remdesivir, did not work. Then we had to start pseudofovir.
How did you diagnose adenovirus conjunctivitis?
Adenoviral conjunctivitis, you can diagnose it clinically, and we have access to IAV, right? You just take the nasopharyngeal swab and
There was a recent, actually, ഒരു epidemic ഒരു 3 months back. I think it was adenovirus.
adenoviral.
Adenoviral around from January to till February, last 3 months, December, January, February, among the adult population,
Yeah.
with a little bit of a lot of morbidity, not mortality, but probably in the immunocompromised patients may have caused it.
Yeah, in pediatric onco, dealing with this adenoviral pneumonia is a huge headache.
Any more?
In the current scenario, right? So, you are talking about the Paxlovid as well as molnupiravir. The recent studies show that we are having sort of hybrid immunity. So there is no mortality benefit by using this Paxlovid. But the studies done during the Delta period, etc., there was mortality benefit for using Paxlovid. Now there is no benefit.
Any other questions? I think we'll move. Thank you, sir. Thank you.
Thank you.
Thank you so much, sir. Next, we have a session on invasive mold infections in the ICU by Dr. Arunalok Chakrabarti. Sir, please.
Okay, good afternoon. Yesterday I discussed with you about the candida, and today I am going to discuss about the invasive mold disease which is there. The common belief in case of the fungal infection in case of the ICU is that people say that we do see candida infection, but we don't see mold infection, because mold disease occurs in this group of immunosuppressed patient, whereas the ICU, where there is a non-neutropenic group of patient, they don't suffer from mold disease. But there is a study way back in 2006 in France where it had shown that out of the all cases of invasive aspergillosis, nearly 50% were there in case of the ICU. And if you see very recent data which have been published in 2024 by Dr. David Denny, where he had shown that first column is about invasive aspergillosis, and in this invasive aspergillosis, if we see the quadrant which I have tried to put into this red portion of the quadrant which I have covered, this particular area is not the neutropenic group. This is having the patient in ICU or the patients who have got COPD. Only the small portion below which is having got the neutropenic group. So there is a considerable understanding gap which was earlier. Now we realize that mold is a very important infection in case of the ICU. This is the global burden which has shown to be 0.2 to 1 million, and the incidence increased during the influenza or COVID-19 outbreak, and you see the mortality is also very high in this group. Risk factors have been seen to be the viral pneumonia, steroid, liver failure, COPD, HIV. These are the group solid tumor which have been found, and source of this particular mold have been found in case of the ICU, specifically in the ventilation area. You see, there is a study which have been conducted in PGI, and this study had shown that air conditioning duct, all of our hospital is having central air conditioning facility, and the central air conditioning area where the colonization of the fungus happened, and this particular causing the high spore count, because we don't have the HEPA filter at the outlet going into the ICU, because there is a compromise because of our resource limiting scenario, because if you have got HEPA filter, you have to change every 6 months. So that's a big problem. And that's why what we have seen that nearly 100 CFU per cubic meter, we do see sports in the ear in the ICU. And it is said that if you have got even more than 25 CFU, even an healthy individual can acquire the infection. So beyond this ear issue, there is also the complex medical and surgical intervention, disruption of the natural barrier, monoclonals and small kinase inhibitor. These are the new risk factors coming up. Prolonged antibiotic, steroid, and aging population are important factors. So, which are the molds which are causing this infection? Majority are because of the aspergillus, and aspergillus cause either invasive aspergillosis or chronic pulmonary aspergillosis. Next is the mucorales, which is very commonly seen in case of the Indian scenario, and rare situation where we see fusarium, scedosporium, all this. So if you see this century, earlier century which we used to have, that is saying that transplantation, leukemia, biological, these are the period which have been there. Now this period has changed altogether. We have different type of risk factors which have been seen in this period. Now, these are the two issues has come up. Just now we have heard the discussion, especially of the influenza and the COVID. Both of these, in case of the ICU, those are patient admitted, if it is being there, their association is nearly 10 to 15% or even up to 20% where you can see the invasive mold disease. And that is in cirrhosis, we tried to look into what is the systematic analysis wise. We found invasive aspergillosis is around 3%. So what happens? Why suddenly respiratory virus cause this invasive mold disease? Once the respiratory virus enters in the alveoli, immediately there is a cytokine storm, and that brings all the inflammatory cells there so that they can combat this virus. And by the time next when the fungus come, there is already exhausted, there is no more cytokine which is remaining, and that helps in case of the fungus to enter into the blood vessel, which have been shown to be the major risk way of development. This I am just saying that there are certain immunobiologicals which are now being used, and that is also increasing in case of fungal disease. You can see there is CNS aspergillosis, there is also mucormycosis which have been seen in this group of patients. Now, what is the total magnitude of the problem in case of the ICU? There are several studies are there, but if you see the variation is quite apart. Like some say 0.2%, some showed 19%. All this depends on there is what type of ICU and also what is the conditions there in presence of the ICU which have been there. So what is in India? We had conducted this multicentric study, and it showed that we have very high incidence, around 10 cases per 1,000 ICU admission of invasive mold disease. What is importantly or interestingly has been shown that yes, aspergillosis is the commonest one, but mucormycosis has been shown in around quarter of the patient. This is very important because our management style would differ from the Western world in this issue. Next important thing is that it is not Aspergillus fumigatus. Aspergillus flavus have been shown to be equal in frequency. We have seen this new risk group like chronic renal failure, chronic liver disease, COPD, these are becoming risk factors. Chronic pulmonary aspergillosis, this particular issue, I'm not sure how much you are aware of this scenario. Tuberculosis patient who have been managed had gone home after treated, completely cured, and after 6 months, when come back with the similar symptoms, you start thinking whether it is a drug-resistant TB or is it a new disease which have come because the same symptoms which have been there. But it has been seen that 20% of these cases are the chronic pulmonary aspergillosis. It is that the usually after TB management, still small cavities remain, and those cavities where this aspergillus get colonized. And we did an study in the community. We found that the CPA prevalence is around 10.3% in those patients who have been treated for tuberculosis. This showed to be very high in there. COVID-19 associated mucormycosis, I am not going into the detail. You all heard about it, knew about it.
but it's a tsunami of cases. Can you imagine? There were around 50,000 cases which have been put into within 1.5 months in the government portal, and the same portal is mentioning that there is possibly more number of cases. Dr. Atul did a multi-center study, and he really had shown that this scam prevalence is seen in case of the ICU is around 1.6%, which have been there, and it had shown that there is the risk factor wise the steroid multiple use and then the diabetes uncontrolled. These are the major risk factor in developing the disease. So in this scenario, what we need? We need a prompt diagnosis. And in this prompt diagnosis, first thing we need to know the local epidemiology. That is one of the important factors. And then if we look into the diagnostic issue, it's very difficult to get sample from the deep-seated area. So here we have to have combination of several factors like clinical, radiology, all together have to make the diagnosis. And there is problem because of the expansion of the host susceptibility. Now we have to think about in many new hosts where there can be possibility of this invasive aspergillosis. Now in case of the neutropenic host, because of the difficulty in case of fungal diagnosis, there is, ERTC MSG has divided them into proven, probable and possible diagnosis depending upon the host factor, radiological factor and mycological factor. But the same thing is not existing in case of the immunocompetent host, what to do about it. And especially if we think about combination of these factors, the challenge remains always in low middle income country. And then there is also the problem in case of the therapeutic issue. Let's try to solve what we could achieve till now and how we can really diagnose and manage in case of mold disease in case of ICU. First thing is that if we look into the radiology, one important thing is that we know in neutropenic host, any fungus which enters in the alveoli, because there is no neutrophil in the blood, it enters the blood vessel very quickly, and because of that we see this air crescent sign, halo sign, all these characteristic signs which have been there. But in case of the non-neutropenic host, where it cannot enter because there is no there is presence of neutrophil which does not allow the fungus to enter the blood vessel, so it goes along the tissue plane, and because of this we see a lot of this non-specific factors or non-specific signs which have been there, like ground glass opacity. Sometimes you see tree in bud appearance, sometimes you see localized bronchiectasis which have been there. But this is one of the characteristic sign. If you can show by CT pulmonary angio that there is a certain cutoff which have been there, it shows that the fungus entering the blood vessel, because of that there is no further going into the dye, and because of this is very characteristic. You can really help in case of identifying the angio-invasive fungus, whether it is mucor or aspergillus, which can be there in this way. Now, if we look into the conventional diagnosis, one is of course collecting the sample is a problem. Now, blood culture, generally the microbiologists sitting here always, if it is a mold, they consider it is a contamination, because generally aspergillus as a mold don't we can isolate it from the blood. But there are two fungi which you need to understand that it can grow and you may miss it. I have seen a lot of those microbiologists missed it. One is the fusarium, another is the scedosporium, and there is also the scedosporium prolificans is now called Lamontospora prolificans, but this is also been going into the blood. That is very important. Now, what about respiratory sample? Respiratory sample having got this more lack specificity. Of course, sensitivity is also not very high, but lacks specificity. If you isolate any mold infection or mold isolation from the respiratory tract in a neutropenic host, it correlates well with the invasive disease. But in a non-neutropenic host, it does not correlate well. So there is really a problem in this aspect. But one thing always think about, if you are looking for biomarker like galactomannan, if it comes negative, think of mucor that is being there. But there are some hopes coming up. So let us see what are the progress have been made. First thing is that if you have got a pulmonary physician in your hospital, and that pulmonary physician is daredevil enough to do fiber optic bronchoscopy, that really improves in case of our diagnosis. Even the CT guided open lung biopsy has helped in case of diagnosis. Look at this PGI data. This PGI data had shown that flexible bronchoscopy could help in diagnosis about 71% cases. And it had shown that the adherent mucus plug is being very characteristic in case of mucormycosis that is being there. So as the diagnosis was not improving, people started thinking, can we develop something as like URTC MSG on the basis of the uh, host factor, on the basis of the uh, imaging factor as well as the mycological factor. The probable group is very clear that if you have from a non-sterile area, if you have identified the fungus, that is very clear, whether it is a biopsy or even if you can take the aspiration, if that is being there, this is a proven group. But probable group, first it came the Aspergillus ICU. Aspergillus ICU definition, they tried to say that first entry criteria is that Aspergillus positive in the respiratory specimen. Anything, whether it is bronchoalveolar lavage or it is put-on, if it is being positive, it is the entry criteria. Then there should be one at least compatible signs and symptoms, and then imaging, and further, if there is any host factor which is if not present in a non-neutropenic ghost, which is the usual risk factor in the neutropenic group, is not being present, then there should be presence of the Aspergillus positive culture in BL fluid. That was the initial situation which have been there. Now, when biomarkers, especially galactomannan and PCR came, this is now called biomarker Aspergillus ICU. Here, if you see what it is there, the patient has either positive Aspergillus in the lower respiratory sample or imaging or clinical sign. Then, if there is a risk factors, the risk factors are the common risk factors as I mentioned: COPD, viral respiratory disease, cirrhosis, if it is being there. And then there is clinical imaging and mycological factor where there is serum galactomannan and of course the BL galactomannan and serum qPCR that had been included in it. But then finally, this is the latest scenario which is being there, where all the societies together, experts, they had developed this Fund ICU consensus definition. These are the host factors which have been there, that COVID-19, influenza, solid tumor, HIV, decompensated cirrhosis or COPD, and then there should be at least clinical factor, then radiology if there is presence of new signs which have been there, and then there is, if there is a biomarker is being positive, or it is the Aspergillus which have been isolated, so it is being put into the probable group. Now, this is a very important study, very recently got published last year. It compared all these three, and it had found that this Fund ICU is the best one, with clinical correlation had been shown up to 53%, which have been there. And if you see in histopathology proven cases, Fund ICU has sensitivity not so good, but still if we can diagnose 50% cases, that is very important. And specificity have been found to be 75% compared to either Aspergillus ICU or the biomarker. So at least there is some progress in case of diagnosis which have been there. So now in risk stratification, earlier it used to be only high risk group means we have to have the hematologic malignancy or transplantation. But now if you see, even severe influenza has been put in the high risk group. So there is a complete change in case of the risk stratification which have been there. We have got severe acute liver dysfunction, then COPD, all these had come in the recent risk stratification group. So this is a very simplified procedure which you can use in the case of your ICU. Look at this. If your patient is at risk of IPA, means I have mentioned what are the possible risk group can be there. In this, if there is a new CT infiltrate or positive galactomannan in serum, or there is presence in non-bronchoscopic sample, like in case of sputum, there is culture positive, galactomannan positive or PCR positive, then go for bronchoscopy. If bronchoscopy possible and bronchoscopy sample, BL sample, if it comes positive, start antifungal therapy. If bronchoscopy not possible, but if you can again show that in presence of the non-bronchoscopic sample it is being positive, consider antifungal therapy. If it is not being present, then don't start antifungal therapy. Mucormycosis, here you have to think about if there is patient is having severe sinusitis, eschar formation, fever, worsening cough, if there is brown or black sputum, chest pain, hemoptysis is there, patient developing these symptoms while developing on having on voriconazole echinocandid. So these are the certain scenario, and specifically if your galactomannan and beta-glucan coming negative, think about mucor. And these are certain radiological features which we have seen more to be associated with mucor rather than aspergillus, that is mycotic aneurysm, Barnes sign, cavitating mass. These have been seen to be more in case of mucor. Now coming to the molecular tests which are coming up, out of this I would say I will not go into the details of the molecular test, but what is really attractive to all of us is the lateral flow assay. This particular test is a point of care test you can do within half an hour without any lab help. Even the clinician, they can do on the bedside, and here in aspergillus this point of care test which have come up, that is really useful. Of course, PCR development is there, especially in case of the aspergillosis. We could standardize this. Mucor, very soon we can develop, but in case of the other fungi, still need to be developed. So the recent emphasis in case of diagnosis is, one is lateral flow assay, whole genome sequencing, and cell-free fungal DNA which have been there. In case of the influenza associated, there is a consensus definition. Proven I am not going in probable group if there is a pulmonary infiltrate along with there is presence of the galactomannan which have been there, can be thought about. But if we look into comparison between this influenza versus COVID, most important thing is that in influenza our galactomannan positivity in serum was even up to 65%, whereas it was quite poor in case of the COVID associated pulmonary aspergillosis. And here we don't see so many cases of tracheobronchitis which have been seen in case of influenza. Moreover, imaging is not helping. Whether it is having aspergillus or no aspergillus, there is no difference in case of COVID time which have been there. So ultimately, 28 expert groups said that nothing doing. You should not be afraid of collecting respiratory sample and processing. You have to have the BL sample, and BL sample should show either the presence of the fungus or the galactomannan positivity should be there. But this is a good practical approach which I have found. This particular approach, if your serum becomes positive for either galactomannan or PCR, start antifungal. Then do the test again, and if possible, do the bronchoscopy. If it comes positive, continue the therapy. Otherwise, you think about stopping it. If there is positive culture or PCR in non-bronchoscopy respiratory sample, then do again try for the bronchoscopic sample. If not possible, do again another repeat sample, then start therapy. And finally, if you have a positive culture of PCR or galactomannan in bronchoscopic sample or the BL sample, start antifungal therapy. These are the uncommon mold which are coming up. And here I would emphasize one of the issue, especially the Cladophila bantiana. This is one fungus which is being seen quite commonly in case of India. Nearly 50% cases of the world is being reported from India. These are certain patients who have got central nervous system infection. These are patients who are mainly immunocompetent, and this is a very important. If you can diagnose this early, then you can save. And moreover, to treat this fungus is very difficult. That's why the mortality is very high in this. Just take a case which we have faced during the COVID time. 52-year man presented with fever, productive cough, and history of COVID-19 1 month back managed with dexamethasone. This patient having got serum galactomannan 0.45, so it's not very clear whether it is positive or not. But patient had got HbA1c 12%. So you can imagine in this particular patient, sputum culture showed Pseudomonas aeruginosa, and when sputum fungal smear showed accepted hyphae, of course thought about there is mucormycosis. But culture grew both aspergillus and mucor, and imaging shows in right, you can see there is a very big cavity, and when pneumatology had been done, it had shown both. And one side you can see there is presence of aspergillus, in another side there is mucormycosis. And that's why I'm saying you don't just think about, oh, you have a diagnosis, you have got mucor. Sometimes it can be, or you have got aspergillus, so that's the end of it. Sometimes this mixture which can be there, and during this COVID time, what we have seen is that around 5% cases where we saw this mixture of this infection that is being there. So in this patient, after initial improvement, perioperative day of 5, complicated with severe sepsis, patient ultimately passed away. We could not save the patient, but we should have started the therapy much early. Now, treatment wise, in case of invasive aspergillosis, which patient should be given prophylaxis? First thing I would say that in case of non-neutropenic host or host, you should not think about giving prophylaxis, as I have discussed yesterday, that it should be at least 10% in that cohort to think about it in case of this prophylaxis. So what about empiric or preemptive therapy? General recommendation is that liposomal amphotericin B, echinocandin or voriconazole. But as our patients is having more number of cases of mucor, if you think about mucor, please look into this, that possibly we should go for isavuconazole or liposomal amphotericin B, which are also mucor active. In targeted therapy, of course, there are now 3 drugs which have been used. Initially, we used to think about voriconazole, but now there are 2 other drugs which have been found to be non-inferior and have been included in it. In case of ulcerative tracheobronchitis, additionally you can give the nebulized liposomal amphotericin B, but you have to follow up the patient, and if there is failure, then think about alternate therapy. So this is again another simplified way of thinking which drug amongst these 3 targeted therapy can be used. There is, you have to think about whether patient has got liver dysfunction, kidney dysfunction, QTc interval prolonged, and suspected or documented azole resistance. If everything is no, then go for voriconazole. If there is mild or moderate liver dysfunction, kidney dysfunction, and QTc interval prolonged, then think about isavuconazole. That is very important. If the liver dysfunction is severe, and if there is suspected and documented azole resistance, then think about liposomal amphotericin B. So this color coding helps you thinking or picking up the drug very easily what should be done. In case of mucor, it's a multi-center or multiple specialty which needs to come together for managing one case, because you need the consultation of the surgery. Surgery is very important. If you can do the debridement, because simple giving antifungal mucormycosis is very difficult to treat, because there is lot of necrosis and the drug don't reach properly. And the best initial drug is of course liposomal amphotericin B. Then you have to go for the step down therapy. But here you have to control the risk factors, especially if the patient is uncontrolled diabetes, you have to control the diabetes. If the patient is on immunosuppression, think about reducing the immunosuppression that would be there. Other issues which can come into case of ICU is again in case of TDM. That is very important. That is been there because drug interaction issue, PKPD issue, which I have discussed yesterday. I am not going into the detail, but these are the usual level which we are expecting that should be achieving there. Certain times, especially in case of voriconazole, if it is higher, it may cause toxicity. That is very important. And here, even in case of the isavuconazole, people say it's a water soluble. Why we need TDM? But Dr. Rajiv Suman has shown that certain patients where TDM it had shown isavuconazole may go very high, and at the same time certain patients where it may not reach. And you see this is in 177 patients when it had been tried to look into. Less than 2 microgram was seen nearly 50% of the cases, less than 1 milligram in 10.2% cases, and more than 5 milligram were in 22.4% cases. So I'm saying even in isavuconazole, in case of your ICU patient, you need to do the therapeutic drug monitoring. So what I tried to tell you is that think of fungus in your patient, especially mold. It exists in your ICU. You should not ignore it. Galactomannan lateral flow, of course, augment the invasive aspergillosis diagnosis, but we are looking forward for the standardization of this PCR protocol, so it should be used more frequently and more routinely. Influenza associated and COVID associated pulmonary aspergillosis is a big challenge because the infection rate in case of ICU has gone 15 to 20%, and we need this algorithm for proper validation. We need this point of care test of lateral flow assay. We have evaluated in multicentric, which is going to publish very soon, and it has shown that the specificity is very good. Sensitivity is found to be around 60%, but even 60%, if you can diagnose, that's quite important one. Cell-free DNA or metagenomics, which we are future in case of the diagnosis, awareness and improvement of diagnostic microbiology laboratory are major unmet need in this scenario. For aspergillus, we have voriconazole, isavuconazole, and prosaconazole, and for mucor, we have to think about liposomal amphotericin B as the first line therapy, step down with the isavuconazole and prosaconazole. Thank you for your kind attention.
Should we be using a combination therapy for this or
See, the thing is that till now we have not a validated data yet. Yesterday also I discussed when to go for combination therapy. I said that it should not be a default approach, it should be a targeted approach. You should identify which are the patients where you should go for this. So this combination therapy had been thought about if there is very severe patient. If you cannot do the surgery, then these are the scenario where you can think about combination therapy. Otherwise, we should not go for combination therapy. Though combination therapy in our big study had shown that though it's not targeted for combination therapy evaluation, but it showed better result. But I am not promoter of a combination therapy until unless there is a good control trial is there showing this aspect. That is still a debatable topic. Though there is a lot of people are promoting in case of combination therapy. What do you feel, Dr. Rajiv?
Let me take your answer first. You said that if you can't do surgery, if there is a large burden of disease, in these patients, combination therapy could be used. That's what you said. What does that mean? That means combination therapy is more effective. I'm just going by what your answer is. I'm just breaking down that answer. And I am a firm believer of combination therapy. Yes, I am. So,
he's a rich man, that's why he thinks of combination. I have not money in my pocket, so I go usually by single dose with that. No, what he's trying to say is very important. Is that as we don't know, we have debate.
Yes.
That's the reason of debate, because his experience showed that the combination giving better result, but in our experience still now we still believe that try with a single and try to do surgery. That is a very important one. If we can remove the mass and then you can easily give a single drug, that's not a problem.
Okay, now let's look at it from a pathophysiological or drug target sort of related consideration. How does amphotericin B work? It produces masses extracellularly on the membrane, and it extracts the ergosterol from the membrane, thereby producing a hole through which intracellular contents leak out, and that's how it kills the organism. Now, what it is actually doing is extracting ergosterol molecule by molecule. And how does the fungus, do you think, will respond to that? By increasing the synthesis of ergosterol. How does it do that? By the operation of 14 alpha demethylase. Now, if you can block that, then to me it looks logical that the azole will actually work in conjunction with the polyene. Okay, so that is one way in which one can explain this. The other thing, I mean, people have criticized heavily David Denning's paper, but it is a 20-year uh, retrospective analysis, 20-year and many thousands of cases. There is huge bias in that. There will be surgeries done in some, surgeries not done in some, and so many other things. But the number is also quite big. So in that they found that when they started the azole with the amphotericin B initially, not later, that gave them the least mortality. Now there are, obviously that paper can be criticized in 100 different ways, but this is the conclusion. And if I think that this is the way in which the two might be actually working, see, there has been this issue in the past that the azole is depleting the target of the amphotericin B or the polyene, and therefore it was thought that the two will antagonize each other. On the other hand, don't we use it as the second choice treatment for cryptococcal meningitis? Okay, so if you cannot have 5-flucytosine, then the treatment of choice is amphotericin plus high dose fluconazole as the second. And now if you look at the ACTA and other things, therefore you have that huge dose of ACTA ambition. So you have the huge dose of all the three. Means, for example, you are having that 10 milligram per kilogram liposomal plus 1200 milligrams of fluconazole plus 5-flucytosine. So even if we believe that that is also going to work, then where is this our question of antagonism gone? Okay, so taking all these points together, I think it should work. I do not have, I mean, nobody has that kind of data with a randomized control trial. There are 100 factors for randomization. You know, the when did you start treatment? What was the burden of disease? Did you do the surgery? Was the surgery total or only partial? And these are just 4 or 5 factors, but there are a million such factors. What was the underlying cause? Could you treat the underlying cause? Was it neutropenic? Was it only hyperglycemia? So many factors are there. It's not possible
Site of
to come.
infection also.
Site of infection also. So many factors. It's virtually impossible to have a proper scientific data. So in the absence of that, and the other thing is my philosophy that in every other disease, don't we use more drugs in the beginning? And don't we have a induction consolidation or induction de-escalation strategy? Don't we have that in tuberculosis? Don't we have that in maybe even HIV for that matter? You now go down to 2 drugs easily. So in so many other instances, we have that. Say severe staphylococcal infection, MRSA, we would be using maybe ceftaroline, daptomycin together, and then going down to one drug. So biologically, to me, it makes sense to use a combination. You give, I mean, your best bet should be used first, not later.
So, Jacob has not put the debate in this particular session. Let me take this session as a debate. I have got each point have got a contrary response. In presence of David Denning, just 2 months back, I criticized his paper. You see, the total number of cases which have been projected in this particular study, I tried to look into it. Where is the most number of cases? This has come from developing country. In the developing country, usually the patient comes to the hospital late, and there the usual outcome becomes poor. And we cannot afford to give 2 drugs in most of the government hospitals. We give 1 drug. So this particular study, which is really biased on the basis of the outcome in case of Western world, cannot be extrapolated the same way which we can think about. First point. Second point is that when we think combination, when it helps each other, what we are combining here, azole and amphotericin. What is the azole mechanism? Azole is biosynthesis that is azole, they are preventing ergosterol synthesis. And where amphotericin works, it works on the ergosterol itself. So if your biosynthesis is low, how the amphotericin B will work more? So it's not that the two drugs you just push in it. Any combination should have a justification of making. I agree on amphotericin B plus 5-fluorocytosine. There is a very clear cut which have been shown in this. But combination of asparpolin and azole, though there are studies which have shown that there is no inhibition effect, but there is no additive effect. So at least in this scenario, I cannot agree with you. Sorry, Rajiv.
But India is still a developing country. So if you said that in that many patients were from developing countries, I am treating those only. No.
See, the thing is that India has got two groups. One very rich group, another not. Who can, you know, what is the cost of the liposomal amphotericin B management? This goes in daily 30 to 35,000 rupees. Daily. He says more than that. I am saying rough estimate of 3 milligram. 30 to 35,000 rupees who can afford? And on the top of that, isavuconazole. What is the cost of the isavuconazole? What is the cost of the posaconazole? It's more than 10,000. It's more than 10,000. If you are combining it, whom you are treating? And where is the most of the patients are lying? At least we are thinking still giving conventional amphotericin B in management. Ask Atul when he had done this study in case of multicentric of mucormycosis. 25% patient could not afford therapy. They had stopped the therapy or could not start the therapy. That is one. Second, we are still using amphotericin B deoxycholate in most of the cases in case of managing mucormycosis. So I am saying you, this is developing country, no doubt, and you are treating in a private sector. Sorry, Rajiv, please don't take it personally. I am really always enjoy debating with him. He is really voracious reader, and I appreciate his knowledge in science in this aspect. David Dennis paper. Strongly disagree with that particular paper because I asked him, why don't you differentiate the outcome between the different developing country and developed country? He said it's very difficult and all those things. We had discussed on this issue there. Sorry.
Sir, we now move on to the plenary lecture on clinical pearls in complex IC infections, lessons from practice. Once again, it's my privilege to introduce Dr. Rajiv Soman, a name that needs no introduction in the world of infectious diseases, yet one that deserves to be celebrated every time he walks into a room. Dr. Rajiv is a consultant in infectious disease at Jupiter Hospital, Pune, who is known for his clinical excellence and remarkable academic achievements. Please join me in extending our deepest respect and a warm welcome to Dr. Rajiv Soman, sir.
I have already been here anyway. Thank you. So these are quiz cases, and I certainly appreciate if all of you participate in that. Uh, okay, so I also subtitled it as the focus of ID round. You know, friends, ID physicians have this habit of poking their nose in everybody's business, and you can imagine what happens to the intensivist when the ID physician pokes his nose there. So these are all critical care cases, and since all of you are into critical care, let's see what you think about them. So here we have a 14-year-old doctor's son. He had chicken pox. He had received an inadequate dose of acyclovir prescribed by his own father. Um, so high fever, toxicity, lethargy, as well as inguinal pain developed. Then lymph node swelling was also noticed, and meropenem, teicoplanin, and NSAIDs were given, and they did a PET scan. With that, they referred for an ID opinion for considering lymph node biopsy. So looking at him, this is the picture of this boy who has had this eruption of recent chicken pox, and this is his inguinal region there. His WBC is 21,000, CRP increased from 65 to 151. The the varicella lesions were healing, and an erythematous painful lesion, as you can see over the inguinal region, with after touching you could see that there is a mild degree of hypoesthesia over it. So what do you think is likely here? They've asked us to do a lymph node biopsy. So TB lymph node, could it be leprosy? Could it be necrotizing fasciitis? Or could it be none of the above? So any ideas? So I want you all to quickly answer. Yes? Anyone? Quick, quick. Otherwise we can't proceed. You won't get lunch. None of the above? Okay. Let's discuss each one of them in detail. It's necrotizing fasciitis. Okay, so we'll come to that. So I like to use this what we call as the Lernex score, although there are some controversies about its use, but I do find it to be quite useful. So here we did have that Lernex score positive for which gives you a high positive predictive value of necrotizing fasciitis and also a good negative predictive value. And we also know that there is a chickenpox and necrotizing fasciitis association, and that is usually due to skin organisms. I think I made this remark yesterday that trying to look at the skin in detail carefully might tell you that this is might be just a streptococcus producing necrotizing fasciitis rather than what is called as type 1, where there are anaerobes, gram negatives, as well as gram positives type in type 1 type of necrotizing fasciitis. So anyway, NSAIDs was stopped, and that is an important thing because toxin production we know is enhanced by giving NSAIDs, especially staph and strepto. Antibiotic was changed to ceftriaxone and linezolid, and this point also I discussed yesterday why I prefer linezolid better than clindamycin in these situations. He was advised debridement as well as joint infection panel, culture, histopathology. Obviously, all that was against parental resistance, and this is what we got in that panel. So this was done by Gitu. She has found these gram-positive cocci there, and the only organism which was detected there was Streptococcus pyogenes. Okay, so this treatment. So no other organism was detected, including this so-called type 2 necrotizing fasciitis due to Strep pyogenes. Culture was negative, probably because of the antibiotics that had been received earlier, and the patient made a rapid recovery. So this case is shown only to emphasize that necrotizing fasciitis should be suspected in children especially who have had a history of chicken pox, increasing pain, swelling in an extremity and all that. And when they did the debridement and all that, it had a good result. Only a small number, only 150 cases have been published so far, but we should keep that in mind. Let's take this case now. So this is a 67-year-old male. He's a diabetic. He has hypertension, hiatus hernia, also a seizure disorder. On 14th of July, he had hematemesis. 2 days later, at home, of course. 2 days later, there was back pain, dyspnea, and he was admitted to our hospital. The chest, CT, everything was done, and empyema was found. The cells in the empyema were 15,000. As you can see here, it's almost a turbid pus-like fluid coming out. High neutrophil counts, high proteins, extremely low glucose. LDH was high, very much higher than the serum LDH and all. Expert MTB ultra joint infection panel and culture were done. The patient was on meropenem and teicoplanin. So with this, the patient was referred for an ID opinion with this joint infection panel report to fine tune antibiotics. So what has been found there? I'll read it for you. Enterococcus faecium, Parvimonas micra, Streptococcus species, Haemophilus influenzae, and Candida albicans. And if you look at resistance genes among the ones in the panel, nothing is there. So how do you analyze this case? This must be post-pneumonic empyema, must be tuberculous empyema, could be either A or B or none of the above. What? Yeah, correct. So none of the above, right? So excellent. Stuck here. So unlikely to be a post-pneumonic empyema. So polymicrobial flora, as you got in the JI panel, is somewhat against it. Underlying TB also, the fluid characteristics are certainly against it. So these are all salivary organisms. So that is something important to remember here, along with others have been found. So this could be an esophageal perforation. Remember, this patient had hiatus hernia also and also had hematemesis. So maybe some other reason such as a tumor, but that would be a long history of dysphagia, weight loss and all these things. Hence an acute esophageal perforation, Borev syndrome or whatever we call it, with mediastinitis can explain these findings better. Hence there was a need to revisit the history and review the CT scan. So on asking, there was history of severe retching along with that hematemesis. So that had preceded the onset of all these other symptoms and whatever happened. And on review of the CT scan, sometimes the ID physician has to review radiology. And what do you see here? Plenty of gas in the mediastinum. Again telling you that this is a esophageal perforation. So pneumomediastinum was found. Then thoracotomy was done. But remember that mortality increases very significantly with delay in surgery. Surgery is also not that easy. You can get secondary leakages and so many other problems, secondary hemorrhages also. So the message is clinicians have been lampooned for having lost clinical acumen and for being over reliant on investigations. So careful attention to both history and radiological findings is very essential. The type of flora that is detected by such a high-tech test, and that too off-label and so on, can certainly point to the source and scenario, although by a very circuitous route. Okay, the direct thing which should have been happening was the proper history, a proper evaluation of the CT scan. You didn't need a joint infection panel to tell you, okay, Baba, this is esophageal rupture. And then delay would lead to unsatisfactory outcomes and so on. So let's take the next case. This is a MSEB, is Maharashtra State Electricity Board. Okay, so he is a engineer with a field job. There was a suspicion of injury or some bite of some insect or something else, maybe on the leg at a place called Ganpati Puri. The lesion had begun as a blister. I think in this era where every telephone has a camera, I think there are some benefits for the ID physician. So you can tell them, "Wo batao time what how was it?" Okay, so and then they will readily show it to you and all that. Somebody has taken a photograph. So I think these kind of selfies are better than. Okay, so that's okay. So this was a blister, and that became a large necrotic lesion, as you can see, over 1 week. Debridement was done elsewhere, several antibiotics were given, but the lesion kept on worsening. With this, the patient presented to a surgeon at our hospital and this case was also referred for an ID opinion. So what is this? No prizes for guessing. This is necrotizing fasciitis. And yesterday Arunalok was about to tell something, so I told him that leave it because tomorrow I want to show a similar case. Okay, so necrotizing fasciitis can develop after inoculation or bite in an apparently normal immunocompetent person with progressive necrosis despite debridement and lots of antibiotics. I don't even remember, but every antibiotic was given to him. Is likely due to a mucorrhallian mold. And now it's not even enough to say which mucorrhallian mold. So you will have to think of what produces necrotizing fasciitis in apparently normal person after inoculation of either bite or soil or something like that. So there is a suspicion of Apophysomyces variabilis elegans as well as Saxenia vesiformis, maybe even syncephalostrum or something like that, all of which have high MICs to amphotericin B. So we asked for histopathology as well as culture because sending in such patients either histopathology or culture is not in the culture of some of the surgeons. So they might just be content to do debridement, bandage the whole thing and leave it. Okay, but this fortunately was done. We also know that if we are suspecting one of these, the MICs to isavuconazole are also somewhat higher, and therefore empirically posaconazole was chosen for treatment. And again, maybe there will be some arguments with our friends here that about the use of higher dose of posaconazole, and I do believe to use a higher dose, target maybe a trough level of even 3 or something like that. So, and this is based on some of our work which we published of IV. How soon do you reach adequate posaconazole levels after IV posaconazole, and also this kind of optimized dosing, especially for a high body weight as well as to get a good result quickly. So this is the typical dose which I often use. So that is 300 BD. The standard dose is 300 BD on the day 1, followed by 300 OD. Okay, so but I prefer to use it this way. Okay, fortunately we had the biopsy and the culture, and this is here for you to see. So which is this organism? You can see on histology, this is a aseptate, fairly wide. It's not branching, so I can't say about acute or right angle, but it is aseptate and it is fairly wide. And this is what to describe. It looks to me white. Almost everything looks powdery white or cotton wool or whatever. I can't describe this. So that is this, and this is on the LPCB mount. So which is this organism, do you think? And what should be continued as treatment? Remember, we have started with posaconazole. So should I continue with amphotericin B, isavuconazole, posaconazole, or none of the above? Microbiologist. Anyway, why am I? Yeah, got it. Because I was timed out probably. Okay, so right. So this was a rather tricky question, that what you began as empiric therapy may be continued, not to be changed. Okay, so yes, so this multitude of MS could not identify this isolate. So Arunalok, yesterday you were pushing for multitude. I agree absolutely, but there are some issues. So I think your good old LPCB mount and all your lectures on conidiation and looking at all these morphological things is extremely important. So even in this day and age, when multi will otherwise shorten time to identification, you will not need sporulation to see what is happening to that organism and so on. And some of these are extremely difficult to sporulate. They won't do that easily for quite some time. So on the basis of all this LPCB mount, it was identified as Apophysomyces species by morphology. And again, here we have Arunalok's work and from PJI, which tells you what are the MICs typically to the various drugs for apophysomices species. And again, it tells you that the posaconazole MICs are relatively less, and maybe that is the best way to treat. We could also grow this organism, although not identified properly, but this is it. And the posaconazole MIC was extremely low, like 0.0625, really very, very low. So the broth microdilution did show a low MIC of posaconazole as compared to all others, and treatment was continued with oral posaconazole, and the patient, of course, debridement, and this is after skin grafting, and we had a good result with this. So remember, a post-inoculation necrotizing infection did not respond to adequate debridement and a whole lot of antibiotics should raise the suspicion of an angio-invasive mold, and therefore it needs both histology and culture. Local epidemiology is important even among mucorales. Multitude of MS may not always help, and the skills of looking at the LPCB mount after morphology and sporulation does help. Okay, so that is something which is very important. We have to consider what might be the antifungal susceptibility in these particular molds. Surgical, needless to say, surgical debridement, even for this kind of cutaneous thing, is extremely important. Antifungal therapy and reconstruction are essential components of management. Okay, let's look at this patient. He's an elderly gentleman, 75-year-old liver transplant recipient on triple immunosuppression. He had severe pain in his upper jaw and ear for 5 days. Now, this was diagnosed as dental caries by the dental surgeon. He was prescribed amoxiclav and underwent dental extraction. Then he also had something on his ear for which he showed a dermatologist. So, furunculosis of the ear was diagnosed by the dermatologist and fusidic acid ointment was prescribed, but no relief of pain was obtained. This progressed within a day or two or few days to dysarthria dysphagia. This developed, and now he went to a neurophysician who prescribed aspirin, vitamins, and pregabalin. Okay, so now since something was there in the ear, some cranial nerves were involved, so maybe non-necrotizing otitis externa. This is the current preferred name for malignant otitis externa. It's the same thing. That with skull-base osteomyelitis and stomatitis was suspected by the ENT surgeon. All this was suspected by the ENT surgeon as mucormycosis as the likely cause, and the patient was shifted to the ICU. With this, the patient was referred for an ID opinion. So what do you see here? You have left 7th, 8th, 9th, 10th, 11th nerves were found to be weak. Okay. This is the picture of his ear, and this is the picture of his palate. So what do you think is likely? Is it a skull-base osteomyelitis due to tooth infection? Or is it cavernous sinus involvement due to spread of cutaneous pyogenic infection? Or is it skull-base osteomyelitis due to necrotizing otitis externa? Or none of the above? Yes? None of the above? So what do you all think? Yes, yes. Herpes, excellent. Okay, so look at it very closely. So you have this 7 now, of course, you have seen these grouped vesicles which have formed pustules, and this is the backside of his pinna, which also shows almost the same thing. And if you look at this very closely, all these ulcers are only on one side. They are only on the left side, especially if you see this one. I think it projects very well. Tomorrow you'll see reading is too good. I have never looked at it behind. So it's better than what I can see on the monitor. Okay, so this is definitely looking like some vesicle which has recently ruptured. Okay, so what is this? He had gone to the ENT. He had first gone to the dentist who removed a tooth, then the dermatologist who will prescribe some ointment, then the neurologist. They are very good at prescribing aspirin, pregabalin, multivitamins, and finally the ENT doctor thought of mucormycosis. So this is the proverbial 3 or 4 or 5 blind men who are looking at the elephant, and all of you got this answer very nicely. So this is diagnostic of zoster Ramsay syndrome, but not just Ramsay, it has gone to other segments also. Okay, so it's Ramsay is only geniculate herpes with 7, but here you have other nerves that are also got involved. Remember that he is a liver transplant recipient. Unfortunately, he has not been given Shingrix or vaccination for this. Okay, anyway, so here you can see on the MRI also you can see that these nerves are edematous. There is absolutely no skull base osteomyelitis, and there were some acute tiny cerebral infarcts. Remember that zoster can also be vasculo-invasive, and you can have in the same dermatomes or same location, but even elsewhere you can have endothelial dysfunction and small infarcts. So then he was treated with pregabalin. I continued, of course, and aspirin too, but also gave famciclovir. So he was planned for a zoster vaccine later. So remember, zoster can reactivate, producing a number of different manifestations, including post-herpetic neuralgia, vascular disease, and encephalitis, especially in elderly. The clinical diagnosis can be difficult if there is no rash or if it is relatively painless. Here, of course, there was no question about it, and zoster vaccination should be strongly considered. Yeah, they get involved. So you can get, it's not strictly dermatomal.
This is multidermatomal herpes
Multidermatomal.
zoster, just like in HIV patient, because patient was heavily immunocompromised, patient has multidermatomal.
Multidermatomal. But everything on this side on. Okay, 38-year-old male patient. He had body ache, fever, cough, and was admitted elsewhere in an ICU. So he was diagnosed as CAP and was treated with pip-tazo, doxycycline, and oseltamivir. We had a lecture in the morning. This is what you see all the time. So 6-7 days later, he was transferred to Jupiter Hospital due to lack of improvement, and he was found to have multifocal consolidations. Okay, so here you can see it's their bilateral pneumonia basically and community acquired pneumonia. So this is the CT and LRTI biofat, that is pneumonia plus panel, that shows you 10 raised to 4 E. coli, 10 raised to 6 strep pneumoniae, and you see various resistance markers such as CTXM, NDM, and OXA48 like. Okay, so what should be done to this patient? Change this treatment. You remember it is pip-tazo, doxy, and oseltamivir. Should I change it to ceftriaxone? Should I change it to casavy-aztreonam? Should I just continue the same treatment, or actually change to polymyxin B, because this is E. coli? It might be harboring PBP3 inserts, the bad ones also perhaps. So casavy-aztreonam also may not work. So should I change to polymyxin B plus maybe meropenem, because S. pneumoniae also may be there, maybe that is resistant. Okay, so what do you think? Yes? Ekdam silent. It's a proper induced sputum, good quality sputum.
Can be changed to the gram negative after hospitalization? So this could be oral flora. And the original organism could be a strep pneumoniae.
Correct. Excellent. Okay, so changing to ceftriaxone looks to me the best bet. So S. pneumoniae is the likely cause here. It is almost always susceptible to ceftriaxone using the non-meningeal breakpoint. So for pneumonia, almost always ceftriaxone will be effective. You will not need vancomycin addition or anything like that. So this is incorrect, because it will work for E. coli if all these things are there. But E. coli is a very rare cause of CAP. It is likely colonizing the upper respiratory tract. So even if you have a good sputum, it will still have to come through the upper respiratory tract. So that is okay. And then this, if you by chance think of using this, ceftazidime itself has poor gram positive activity, and aztreonam has absolutely no gram positive activity. So this is not going to be a good idea at all. So continuing the same is also probably incorrect because ceftriaxone is preferred to piptazo for S pneumonia. Remember that CTXM doesn't come out from S pneumonia at all. Okay, it doesn't produce beta lactamase. And for the same reasons, changing to polymyxin B and meropenem is incorrect. Okay, so always look not just at the report, but the patient profile, what has gone into him before, how many days have passed, and all these things. In fact, that is the reason why when NATO showed that data, even from ICMR, for community acquired pneumonia and all that, some of these organisms were reported very strongly, including E. coli was there, Acinetobacter, Pseudomonas, and all that were there. So obviously, that data is something obtained after many days of being in the hospital, where flora will have changed. Okay, so this is a 60-year-old male. He has NHL on treatment at Rajkot. So fever, cough, mild dyspnea started on this 31st December 23. It's an old case. Then he was admitted to ICU soon after in January 24 under the care of an oncologist as well as ID physician. So what is his profile? NHL on treatment. He had low WBC platelets. He received GCSF as well as single donor platelets. So this is his treatment. Can you see it? Okay. Venetoclax, acalbrutinib, rituximab, bendamustine, many courses here. Then again this, and treatment wise, azithromycin, fluvir, cefosulbactam added, then fluconazole, doxylinezolid given, and finally fluconazole changed to voriconazole. So with this, the patient was referred to Jupiter by teleconsultation. Patient is remotely, safely away from me. Okay, he is in by teleconsultation. So this is the picture which they sent, which was done on 2nd January and on 6th January. Have a good look at it, but I'll show you something even later. They also sent this, that the serum galactomannan was 0.4 and beta D glucan was 200. So what do you think is most likely here? PCP, IPA, bacterial pneumonia, or none of the above? You want it again? CT? Okay. Oh, you have those plasmas there also, so they can also see it. Oh, wonderful. Okay. So, what are your ideas? Beta D glucan positive, huh? Yes. PCP, yeah, possible. Anything else? So each one of them could be possible, but it's none of the above. Let's see now. PCP, rituximab. Did I tell you rituximab also? Yeah. So rituximab is a risk factor for PCP. The patient was not on TMP SMX prophylaxis. The symptoms were compatible with PCP, agreed, but radiology is not suggested. The positive beta D glucan could be related to the blood products, single donor platelets, blood, everything was given to him recently. And in PCP, usually it is greater than 523, 534, whatever. What about IPA? IPA, certainly host factors are present, especially acalbrutinib. Now, acalbrutinib is a little advanced over ibrutinib, which is strongly associated with IPA and all that, but even acalbrutinib, a few cases are there. But if you look at the radiology, again, it was not suggestive, and I'll come to that. Serum galactomannan was negative, although the patient has had neutropenia recently. Beta D glucan was positive, but both would have alternative explanations. Bacterial pneumonia, again, rituximab is a risk factor, especially for encapsulated organisms such as S. pneumo, but the radiology was not suggestive. In radiology, what I mean is the evolution of the lesions is not suggested. What about CMV? We could consider that rituximab is a risk factor and BAL CMV viral load can help. But remember that there are no well established cutoffs for BAL CMV viral load, which can really help. Influenza, COVID-19 can all be considered. So although these things were sent by teleconsultation, it is actually important to look at the scans frame by frame. Okay, so let's look at this on 2-1 and what happens there on 6-1. So what was seen here has disappeared on 6th. Okay, and what was not there has appeared here. Similarly here, nothing was there on this. This is a comparable film on 6th and you find a large lesion has developed here. And here again you see that this lesion was there, that has gone away, and this has come up here. In short, there are GGOs, there are nodules, and there are migratory infiltrates which are suggestive of chronic organizing pneumonia. Remember, the patient has had 3-4 courses of rituximab. So rituximab induced cough was likely, as it is known to occur after 3 months or 4 doses, and more common if GCSF has been received. Obviously, this is a radiological clinical diagnosis, but you need some proof. So you need a biopsy perhaps to show chronic organizing pneumonia and nil microbiological in order to rule out other diagnoses as well as confirm by biopsy. And the importance of this is you treat it with steroids and you can get a dramatic response. Okay, so sometimes an ID physician can be thrown off balance because you are shown a non-infectious thing. So that also needs to be kept in mind or at all times. So the focus of ID rounds in the ICU is slightly different. So the ID physicians are more concerned with colonization or invasion. Is it a non-infectious cause? Is it a self-limited infection? They'll definitely give some advice, even if it is not wanted or unwanted, about the what might be the correct specimen, when to collect it, and all that, and maybe to interpret the microbiology reports. At least read the notes or comments written by the microbiologist. So at least that can be done by the ID physician. Surveillance, antimicrobial stewardship, and infection control are all important there. Then frame the treatment, make a sort of a syndromic diagnosis. That is something which is very, very important, and unfortunately I find that to be lacking among most physicians today. Okay, so what is this syndrome is the most important question which should be always kept in our mind. Then we must know about what the guidelines tell you, and even more importantly, we must know what is the local epidemiology, not just of organisms but the mechanisms of resistance and so on. Source control is doubtlessly important all the time, and one has to insist on it. Sometimes the surgeons may be reluctant, but also let me tell you that often biopsy is needed rather than empiric therapy. I sometimes say that a invasive procedure and a biopsy is better than toxic, ineffective, sort of wasteful, meddlesome empiric therapy, because it doesn't give you anything, and the costliest antibiotic or team of antibiotics is the one which does not work. Okay, so we need to know the diagnosis. Paying a lot of attention to these PK/PD indices, and that is also a growing science. To what extent it helps really and actually makes a big difference is somewhat difficult to demonstrate in a clinical trial. Again, this same thing, like the value of combination therapy has not been easy to show. Similarly, the value of all these extended infusion techniques and all that, if you actually see the trials, you find marginal benefit. You're not so sure how much is it benefit, but the science behind that is robust. So looking at interactions is another business of the ID physician, looking at adverse drug reactions, de-escalation and termination. And today, like I said earlier, today my main business is to de-escalate, terminate, rather than come up with some new drug which the intensivists don't already know. Okay, no such drug exists. So it's mainly to stop. And fortunately, there is some evidence there. This is not my work, it is published. So involvement of the ID team improved the appropriateness of antibiotics and made a difference to survival. So if there is hard data on this, then I think having an ID physician along with you on your rounds can be a decisive advantage. Okay, I'll stop here before time. Thank you.
Any questions? At this point of time, I think we'll break for lunch. Quick lunch. We'll be back by 2.